Hello, John.
Good morning, Sam. How are you?
Well, I'm fine. What about you?
Good, good.
Please, Hyotaka
Yeah,
has
I'm sorry, Sam. I don't. What'd you say?
upgrade Hyotaka. He is
Okay,
in
yeah,
attendees.
yeah. We're ready to start.
Yeah, yeah. He is the first speaker.
Who is? Oh, okay.
Make me
Oh,
host.
you're looking pretty dapper. I better get dressed up. Okay, the first speaker, and let me look here.
He is in attendees.
Hirotoka Haragawa.
Yeah, yeah.
Right here. I don't know what they think when I invite them in. It's like, no, I'm not coming in. They just say, no, I'm not coming in. How you doing, Dr. Hasagawa?
Hey, can you see me now?
Yes, I can see you and hear you.
Okay,
Yeah,
great,
yeah.
great. Yeah,
And here you too.
great. Nice to see you, Professor Sami.
Nice to see you too. Thank you.
Thank you very much for inviting me in this great, conference. Thank you very much.
The big
Thank you.
conference, huh? Sam did a good job getting all these people together.
Yeah.
Indeed, indeed. Yeah, it's amazing.
So,
So I think my talk will start in 15 minutes. Is that right?
right, right.
Yes. Yes.
Okay, perfect.
Check your email.
Perfect, perfect. Okay. Yeah, just let me know when I can start my
Oh,
presentation.
okay.
Yes, we will.
First cup of coffee. You don't drink coffee, you drink tea, right? Two minutes, okay.
Mind if I share my slide?
Go ahead. You want to practice? Go ahead. We haven't started yet.
Right.
Okay, now to make it presentation mode.
How's this?
Yeah, perfect, perfect,
All right, great. Nice.
perfect. Okay, you can get off that now because I have to introduce you. Oh, Sam's going to
Oh, okay,
introduce
sure. All right, all right.
you. Yes, you can always come back. Because
Sounds
otherwise
good.
the people don't see you. All they see is the little picture in the corner, like a little 1 inch by, and
Sure, sure, but they don't
by the
have to
time they
see me.
get
They
to
they
the,
have to see my
well,
presentation.
it's good. You know, you're developing a reputation for your career right now.
Great,
I
great.
mean, yeah, you want other surgeons to know you.
Sounds good.
So,
Thank you.
yeah, so they can call you if they have a problem, whatever. In Japan, you're from Japan?
Yeah,
Okay, what Tokyo?
yeah, Tokyo.
My brothers were in Sapporo
Oh, really?
playing hockey,
Oh,
ice
great.
hockey.
Yeah, ice hockey.
Yeah, it's a big sport up there in the mountains.
Mm-hmm. Mm-hmm.
They enjoyed it. They
That's enough.
miss eating meat. They because they're big meat eaters.
Yeah.
Okay, Sam, whenever you're ready.
Yes, ready.
Okay, here we go. 10, hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, very early morning from Miami Beach. It's 3 o'clock in the morning. Welcome to day 2 of the Wisdom webinar. We had a lot of great speakers yesterday. We have a lot of great speakers today, starting off with the first one. And Sam, the irrepressible promoter of this conference, is going to introduce him. Well, good morning, Sam.
Good morning, John. Thank you. Thank you all for joining us yesterday. This is the second day of ninth EWNC Academy Anniversary Annual Congress. And this is the 79 collaboration with Neurosurgical TV. This will be a channel for neurosurgery everywhere. And now we will start second day by presentation of Professor Hirotaka Hasegawa. Please start sharing your screen. Thank you all.
Thank you very much. I'm gonna share my slide. And all right, can you see my slide now?
Yes, please go ahead.
Okay, perfect. Perfect. So my name is Hirotake Hasegawa from Saitama Medical Center, Saitama Medical University. First of all, thank you for inviting me here for this great meeting. I'm really honored to be here. So my topic is Beyond the Dura, the forefront of endoscopic transnasal surgery. So the conventional skull-base approach is excellent, actually. It's very nice, but it's highly invasive because of the large skin incision and extensive craniotomy and so on. And compared to that, endoscopic transnasal surgery is, needless to say, a minimally invasive approach. And with that, we can obtain a direct access without crossing critical nerves or requiring significant brain retraction. And it's began to apply for a wide range of skull-base lesions, including intradural pathologies. However, if you want to cross the dural boundary, you have to be aware because you'll see brain, nerves, arteries, and perforators, which requires, the fine dissection. And also, there's a risk of CSF leakage after surgery. So you have to master reliable skull-base reconstruction. And to do that, you're gonna need wide surgical field. And this is my endoscopic microsurgery concept. So how to get done with the reliable skull-based reconstruction? This is actually just my opinion, but I would do. So this is an inlaid margin, and this is the inlay fascia, which is sutured to the dura, and then onlay fascia, and then the rigid reconstruction like bone and hydroxyapatite plate, and also sphenoid mucosa covered with the oxidized cellulose, with the sealant like adherence, etc. Also sinus packing with soft material like nanopore. And how to do with the dural suture? I actually like to do water-tight dural suturing for literally any cases with the exposited grade 3 CSF leakage. Um, I do two types of sutures. One is multiple single stitches, and the other is continuous sutures, depending on the location and the availability of the materials and such as type of things. And then I summarized my techniques in the neurosurgical focus in this year, so please check later if you are interested. But the bottom line is that with this technique, I would say mostly the risk of this leakage is like the almost 0% with this beautiful stress. So also it's very important to understand anatomy and simulate the good surgical simulation before surgery using this type of 3D simulation tools. This is, by the way, the grid, which was invented in the correlation of the Compass Corporation and the University of Tokyo. So let me show several cases. So this is the juxtacellular lesion, kind of the large craniopharyngioma in a 52-year-old female. The point of this case is that there are many perforating arteries like PCOM and anterior choroidal, and even the perforating arteries from the basilar arteries back here, and also in front. You got aware that there is a superior hypophyseal arteries. So how can I manage that? So this is just after opening the dura, you can see the superior hypophyseal artery up front here. So this has to be preserved completely because it would cause the damage to your vision. And this is a peak on the left side. It's very fine and slender, but you have to preserve it to preserve neurological function. And this is the dissection plane from the third ventricular floor. And you can find the right P2, P-com, and third nerve. And this is the pulsating artery from the top of the VH artery. On the left side, you can find the anterior choroidal artery. And then also up there, you can find the optic tract and then the perforating arteries from the top of the carotid artery. So you have to do fine dissection. This is the P2. You can also do fine dissection to preserve the vessels and nerves. This is the premammillary artery, which is the most significant branch of the PCOM. And then now the tumor is completely dissected off of the brainstem and the perforating arteries. So I was able to obtain near total resection for this particular case, and also arterial branches are preserved. So this is inlay fascia, which is switched to the dura in a water-like fashion. This time I used the continuous suture and the multi-based reconstruction, as I said. So the patient went well, no deficit at all. Another case, the large plano-sphenoidal meningioma. So again, for this type of the supracellular tumors, you gotta be aware that there are multiple arteries that are involved inside the tumor. In this case, the carotid artery and then especially particularly the anterior cerebral artery and its branches are completely involved. So this is one opening of the anterior skull base, the plantar, and then the upper side of the cell. The first, you have to do an internal decompression to mobilize the tumor, and this is the optic tract. And this is the acorn complex, which is stuck into the tumor. And you have to do a sharp dissection to preserve these fine vessels. And then the left A1 is also completely embedded in the tumor. And this time you have to also do a sharp dissection technique to mobilize the tumor. So unfortunately, you can see this is the feeding pilar fetus from the left area, which has to be coagulated. Otherwise, you will cause the injury to the A1. This is a left fibula. But be careful not to injure this artery because it's going to cause significant neurological problem in your patient. So again, there is a minor operating artery from this fibula, so you have to do fine coagulation and fine cut. And finally, I was able to achieve near total resection with a small physical tumor remnant in attacking to the tumor, but I think it should be okay. So near total resection without causing any neurological deficit. So what about the midline posterior fossa lesions? So I like this classification using the two lines. One is Durello's canal, and the second is gross pharyngeal meatus. So you can divide the posterior fossa into three parts: upper, middle, and lower. And for the middle clival lesion, you gotta do transcribal kind of standard approach for this type of lesion. And then if the tumor is sitting more lower, you have to do transpharyngeal transclival approach. And when the tumor is sitting upper clival lesion, this is, I think, one of the most complicated transnasal approach, but you gotta do transclival approach with pituitary transposition so you can connect the suprasellar regions and the upper clival lesions. So this is the clival meningioma sitting in the middle and the lower clivus. So I did transcribal and transpharyngeal transcribal approach. So for this particular case, I mean for this type of tumor, I raised the pharyngeal flap from the scratch as a part of creation of surgical corridor, and this is the drilling of the clivus. And then after that, I also cut the flap lower to expose the foramen magnum, and I added bone removal to completely expose the lower edge of the tumor. And then the important part is always the internal decompression, so you can mobilize the tumor. And once you can mobilize the tumor, you can dissect these tumor pieces off of these arteries. This is right side BA, and this is the anterior spinal artery, which is the most significant, most fragile arteries in this particular area. And this is the left side BA. So finally, I can obtain the near total resection. And then again, the multi-layer scopic reconstruction is very important. Duration in the first year and only first year. Blue is following group. And the following years, the fat for a little bit. And this is another pharyngeal flap to completely seal the mucosal dehiscence. So gross total resection without causing any damage. This is a very interesting case, but posterior clival meningioma. So for this particular case, like I said, it's very important to do sorry, is it moving? Maybe no. It's frozen.
Yes, we can hear you.
Let me see. Sorry. It's actually stopped.
We can hear you fine.
All right, let me restart again. Can you see my slide
Yes.
now? Okay, perfect. Right, so sorry about that. So this is the osteocranial region. First thing is to do a pituitary transposition to connect the sacrocellular regions in the clavicle region. And then you gotta be aware that many perforating arteries are involved inside the tumor. This is the superior hypophyseal artery on the left side, and this is the PCOM. So always gentle internal decompression, dissection, and then you can it's very important to create a space before doing any dissection. For this particular case, I divided the tumor into two smaller pieces along with the vaginal artery, and I removed the right side first to create the space on the right side, and then with using the created space on the right side, I mobilized the tumor from the left side to the right side to enhance the dissection between the tumor and these perforating arteries. And this is a surgery. And then here you can see the sixth nerve and the sixth nerve all completely preserved. This is a near total resection. For the clothing part, I don't think we can do any watertight suturing for this particular case because of the pituitary transposition. But I will try to yes.
Excuse me, Dr. Hirotaka.
Excuse
Sam won't tell me if there's an audio problem. Is there an audio problem? Sam, is there a problem? I'm not hearing it well. Are you hearing it well?
Oh, really?
No.
Okay, can you
There's
start?
something
Your audio seems to be not working correct. Can you turn your audio off and turn it on? Turn it off and on. Your audio.
Okay, let me.
Yeah. Turn it on and off.
How's now?
Now
Better?
it's okay. Yeah, it's better.
Okay,
Yeah.
perfect. Sorry about that.
Okay.
Anyway, so for this case, I was able to achieve near total resection without causing any deficit. So this is kind of interesting case. So CP angle tumor, how to tackle with that. So this is the CP angle epidermoid cyst in a 29-year-old female. So the point of this case is that there are many cranial nerves and arteries. So how to do that? So this is the transcriber case because the level is just a middle fiber, so very standard transcriber approach. But I removed the bone lateral a little bit more than usual, and I also removed the boson cell and posterior cranial process to reach the higher level. So this is the up in the dura.
Asigawa,
Right.
I think there is something wrong about your network. You can close the video, your video, and continue to make audio more.
You don't see my video?
Yeah, stop your video.
Okay. All right, I stop my.
Yeah, please try.
Okay.
Okay, go ahead.
Restart.
Yeah, please.
Okay. So the when you remove the the tumor, it's very important to remove the tumor capsule as well because it's gonna, if you leave these capsules, it's gonna recur in the long run. This is
Sam,
the
I'm not hearing it at
final
all. I'm not. It's terrible. I
Still
think you
the
may have
same.
to start. I think you may have to start your Zoom again, and you can
Yeah.
come back to the same place, but restart your Zoom. Turn off your computer because the sound is terrible. Okay, so
Hasegawa,
restart your Zoom.
Okay.
Hasegawa,
Okay, yeah,
I
Sam, he
think
has to
this is
restart. He has to restart the Zoom. The sound is terrible.
okay.
Okay, please restart. Okay, turn
Restart,
your
okay.
computer off completely.
Okay, and then I'll be back, okay?
Yeah, please.
Okay.
It's been terrible since the start.
I thought it's my network. I have tried many options, but
Well,
it's not
you
going
try
well.
to help, but nothing helps unless you reboot. You could try all it. We tried and tried, but it kept going back.
Okay, we can start by Nevas.
No, he's coming right
Lose
back. He's
time.
coming right back. He's coming right back. Let's wait. Let's wait for him. We can't do that to him. We can't split up his presentation. He'll be back. Sometimes it hurts, but sometimes you got to do it. You got to stop the show and I keep hesitating because I keep hoping, well, it'll get better, it'll get better. There's Abby. There's Harshad. Little technical difficulty. We're having trouble with the sound. And we had to make the corporate decision to restart. Hmm. Hey, you got to watch in the panel, Sam, and he's not back. Watch, he's not trying to get in. I'm not the host, so.
Okay, I think we will start with Nevas, and we will back again to Hasegawa.
I don't think it's a good idea, Sam, to start another one.
Yeah, yeah. Please, Nevas, please start sharing your screen.
Sam, you're not starting. No. We're not starting another one. We're not. Definitely not. We're
Yeah,
gonna wait. We're gonna wait for him.
it may take time. So
No,
to not
we're
lose
not gonna
time,
restart. We're gonna wait till he comes back.
okay, he's coming back.
Okay, he's
Thank
back.
you.
Okay. Go ahead. Take it away. Hirotaka.
Okay. Okay, let me try again.
That's better. The sound is better. Just start where you left off.
All right. Sorry about that.
Okay.
All right, can you see my slide?
Yeah, you put it on present. There you go.
Okay,
Perfect. Perfect.
All right,
okay.
thank you. All right.
B-
So
Hasegawa,
again,
Hasegawa,
this is
sorry.
yeah,
Please start from the beginning because we didn't understand.
start from the scratch.
From the
Where
beginning.
should I start? Beginning?
Yeah.
Oh, okay, sure. Here?
Okay, go
Mind
ahead.
if I start from here?
Okay.
All right. So all right. Let me restart the presentation again. Sorry for my connection problem, but so the conventional skull-based approach is very effective, but it's highly invasive because of the large skin incision, extensive craniotomy, etc. And compared to that, endoscopic transcatheter surgery will give us direct access without crossing critical nerves and requiring significant brain retraction. So it's very nice. However, if we want to cross the dural border, you gotta be aware of a few things. So the first is there are brains, nerves, arteries, and perforators. So you have to do very fine dissection like microscopic surgery. And also there's the risk of CSF leakage after surgery. So you have to do reliable skull-based reconstruction. And to do that, you gotta achieve wide surgical field up front. And this is the concept of endoscopic microsurgery. And in terms of the skull-based reconstruction, this is my opinion, but I would love to do multi-layered skull-based reconstruction based on dural suturing. So the first layer is inlay duragen, and then inlay fascia. And this has to be sutured to the dura in a watertight fashion, hopefully. And then only fascia, and then rigid skull-based reconstruction like bone on a hydroxyapatite plate, and then sphenoid mucosa, sealant like adherence, and sinus packing with soft material like nasopore. So in terms of watertight dural suture, I know it's kind of challenging techniques, but once you used to doing it, I think you can finish it within 45 minutes or so. And then the risk of CSF leakage magically will go down to almost 0% after implementing this type of technique. So I'd love you to do this technique. I summarized my technique in the neurosurgical focus in this year. So if you are interested, please check later. So this is the another important point, the three-dimensional computer graphic basis pre-operative surgical simulation to help understand the anatomy and determine optimal approach and facilitate surgery, etc. So I'm gonna show several cases. So this is the juxtacerebral lesion. So the first one is large craniopharyngioma in a 52-year-old female. The point of this approach is that there are many perforating arteries like PCOM, anterior choroidal arteries, superior hypophyseal arteries, and perforating arteries from the basilar artery. So let's start the case. So this is the tumor. You can see the superior hypophyseal artery at the front of the tumor. So I have to preserve it. So and then you can see the PCOM here. So this is the PCOM completely involving the tumor. You gotta do fine dissection to preserve these perforating arteries from the PCOM. And also dissection from the third ventricular floor. You gotta do meticulous technique. This is the right side of P2, PCOM, and third nerve. The perforating arteries from the basilar. Again, the left side, you have to dissect the PCOM, and this is the anterior choroidal artery. Also, you have to do fine dissection, optic tract, and then up here, you can find the perforating artery from the top of the carotid artery. So again, you have to do fine meticulous dissection. So this is the P2 fine dissection because of the bad adhesion there. And this is the premammillary artery from the PCOM, which has to be preserved in the tumor immobilized to the center. And now it's getting completely dissected from the brain stem. And this is the final view. You can nicely see all the branches, arterial branches are preserved completely.
For this case, I did a continuous suture in the fascia to the dura, and then on the fascia, and then the mucosal flap as usual. So no post-op deficit, and tumor is near totally removed. This is another interesting case with a large plano sphenoidal meningioma. Again, many arteries are involved inside the tumor, like carotid artery and then anterior cerebral arteries and their branches. So the first important part is internal decompression after wide opening of the dura. And this is in order to mobilize the tumor and prepare for fine dissection later in the stage of the surgery. And this is such a fine dissection from the ACOM complex, and then A1 is completely involved inside the tumor, which has to be dissected. And then you gotta be careful because in this case, there is a fire feeding arteries from the A1 like this. So you have to do point coagulation and fine cut to preserve perforating arteries. And this is also a fire feeding from the left human arteries like this. Again, you have to do point coagulation and fine cut to completely preserve these left human arteries. And then the rest of the tumor is progressively removed. So finally, I was able to achieve a near total resection with tiny small pieces of tumor. So again, near total resection without causing any brain damages at all. So regarding the midline posterior fossa tumor, I like to use this classification system using two lines. First one is the Durero's canal, and the other is gross pharyngeal meters. With these two lines, you can classify posterior fossa into three parts: upper, middle, and lower. For the middle clivus, you have to do standard transcriber approach, but when the lower when you tackle with the lower clival lesion, you gotta do pharyngeal transcriber approach, and then for the upper clival lesion, you gotta do transcriber approach with pituitary transposition. So this is the clival meningioma in the middle to lower clivus. For this particular case, I will do transcriber and also pharyngeal transcriber approach to completely expose the tumor. And then for this type of tumor, you can use the nasopharyngeal flap, which are usually raised up front as a part of creating the surgical corridor. This is the transcriber drilling to expose the dura. And then after that, you have to also expose the foramen magnum. So caudal dissection. And then this is the dura of the foramen magnum. And then after that, it's very important to do internal decompression so you can mobilize the tumor. For the later dissection, this is the basilar artery. And I always follow this type of large arteries. So you can divide tumor into smaller pieces. And this is the right VA. This is a very important artery, anterior spinal arteries, which has to be preserved. And this is a lesser VA, also sharp cut, along with the artery. So you can divide the tumor to smaller pieces. And this is the final piece of tumor. So I was able to achieve near total resection. And for scalpel reconstruction, again, the inlay duragen, inlay fascia, and then onlay fascia. And then for some pieces of fat, just to fill up the space in the clivus, and then covered with the nasopharyngeal flap to completely seal the mucosal adhesions. So gross total resection without any deficit, and her symptoms went away. So this is an interesting case with the posterior cranial meningioma. So for this particular case, because the tumor is sitting in the upper clivus, you have to do a transcameral approach with pituitary transposition in order to connect suprasellar regions and the clival region. And to do that, you have to remove the posterior cranial process. And you see the stalk here. And this is the superior hypophyseal artery, which has to be dissected sharply to preserve it. And also you can see the left pecon completely embedded inside the tumor with its perforating arteries. And then for this type of cases, I think it's very important to create a space before doing any fine dissection technique. So for this case, I cut the tumor along with the vaginal artery. Sorry, it's all again. It's the video is stopped. Sorry. Yeah. I'm really sorry. Let me get up the presentation.
I think we may have to skip the video.
Yeah, I think so. But
Mm.
let me. It's frozen now.
It's too many tech problems.
No.
Go back, go back.
Yep. Let me check
Okay.
again. I'm restarting my presentation.
Okay,
Sorry about that. Yeah, and I will skip that video. All right, now I got
okay,
back
please share the video.
the
Please share,
presentation.
the video is
Yeah,
not being
I know.
shared. Share it, please.
All right, let me see. Okay. I think I have to skip this video. Sorry about that. But the result of this case is very nice. I was able to achieve near total resection without causing any deficit. So now let's move on to the CP angle lesion. So this is the CP angle epidermoid in a 29-year-old female. So because the tumor is sitting in the lateral side, and then the approach window is very narrow compared to the ventral medial posterior skull base regions. But you can access this type of region with transnasal approach by making a wide surgical field, particularly to the right side for the particular case, to expose the inferior petrosal sinus, and also I drill the jugular tubercle quite a bit to allow for lateral retraction of the dura. So this is the sixth nerve. So you can see the tumor here, the vaginal artery. And it's also very important to remove the tumor capsule for epidermoid cyst, because if you leave it, it will recur. So I meticulously dissect the tumor capsule off of the brain stem and the arteries. So this is the upper view. You can see the vaginal artery and mammillary bodies and certain nerve. And with using the 30-degree endoscope, you can also see the fifth nerve and thorium. And then also this is the final view. You can see the seventh and the eighth nerve here. So oh, God damn it. I don't know why today connection is not very nice. Very sorry. Okay, I'm gonna share my screen again. All right, the last one is craniovertebral junction. So this is the recurrent foramen magnum meningioma after the transcranial surgery. And because the tumor is medial to the vertebral artery, in the previous surgery, they were able to remove the tumor part only lateral to the vertebral artery, and the other, the 70% of the other part in the midline was left, and it's recurred. So I took her to the OR, doing the endoscopic transpharyngeal transclavial approach. So again, nasopharyngeal flap is very important for the later reconstruction. And for this particular case, you can see the C1, and which is also removed. The upper side of the C1, and you can expose the odontoid process. And I also removed the whoa, it's not good. So sorry, I must skip the case. Okay, so so this is kind of a very tough tumor. So I used the sample to do the internal decompression. So generally, I mobilize the tumor off of the left side of VA and then the hypoglossal nerve. So this is the anterior spinal arteries. Really adherent to these arteries and the brainstem. So I couldn't take out all the tumor. Instead, I left very small pieces of the tumor in the ventral surface of the brainstem, but I believe it's okay. So all the vasculature, all the cranial nerves, and the brainstem are completely preserved. And I use the Duragen, and then again the near watertight closure using the 5-PDS for this particular case. And I use the nasopharyngeal flap to completely seal the mucosal dehiscence. And then this is a near total resection without causing any neurological damage. So let's conclude my slide. So now you can use the various transnasal corridors, and also you can use the minimally invasive transcranial corridors, which I didn't demonstrate in this presentation, but you can do it. So now you can explore the possibility using your imagination, and also you can assess the feasibility of your imagined approach through surgical simulation, and you can go and move to. Thank you very much. And sorry for my bad connection. Sorry about that.
Thank you, Dr. Hasegawa, for this nice presentation. Is there any question?
We can always repeat the video later, Sam, okay?
No question, Samay. But compliment to Dr. Hasegawa for beautiful cases that he showed. No question. We are seeing and witnessing the development, growth, and explosion of endoscopic work. And Hasegawa is indeed the leader, and my best wishes to him.
Don't think he's going to sneak in there, the king. You're going to sneak in without an announcement. Welcome to the king.
There's a question in chat box asking about if you get help from ENT for exposure and closure.
No, not at all. Yeah, they are busy. They are doing their jobs. So I do these surgeries by myself.
Beautiful job. Thank you, Hasegawa.
Thank you very much.
Thank
Thank
you.
you. And now shift to next speaker, Dr. Navas. Please start sharing your screen.
I hope it doesn't
Thank you,
continue.
Dr. Sam. Is my screen?
Presentation mode, please. Please.
Yeah.
Yeah, perfect, perfect.
Yes. So, thanks again, Dr. Sam. And this is about, endoscopy. Again, endoscopy has been revolutionizing spine pathologies and dealing with spine diseases the last decade or so. But still, there is an ambiguity regarding the type of terms used in here, type of endoscopy in spine pathologies. It was still ambiguous in the nature of the wordings used. For example, there is this unilateral biportal endoscopy where you put two incisions. And then there is a MED where you use the tubular retractor and put in a scope through the tubular retractor to address the pathology. In full endoscopy, it is strictly limited to any port where the working channel, the illumination and everything is through a single port. That's the deal with full endoscopy. So we will see some case scenarios and how full endoscopy has helped patients and maybe surgeons also in dealing with spine pathologies. So this is what we used to see at 2 or 3 decades back after a lumbar disc surgery, the paraspinal muscle spleen strip of the midline, you can see the full laminectomy. Of course, and it's all about being how minimally invasive, how to lessen the collateral damage, and how to address the pathology, achieve the same goals to less and less damage to surrounding structures. So this is one picture I always love why paraspinal muscle retraction should be avoided. You can see this is a percutaneous, this is open recuperous. You can see the muscles here prior to fixation, and after 1 year, you can see that the muscles are replaced by fat, mostly due to the stripping them of the spinal process. So they are almost replaced by fat in the post MRI after 1 year. So then there are various studies and there how the muscle retraction causes elevation, CRP, and all the muscle restriction and all. And then the forerunner of endoscopy, I would call, is the tubular retractor, where we minimize that big incision to the 18 mm or 13 mm or 16 mm tubular retractors to the pathology. So this was maybe the forerunner of endoscopy, I would say. And once you put in the scope through this, it is called an MED, microendoscopic discectomy. You can put in the tube tubular retractor, block it, and then maybe do your surgery to scope through this hole. But then we will see case scenarios and see how full endoscopy surgery is being addressed. So this is a classical case, straightforward case. So, L5 on this right side. So once the conservative stuff fail, your options are surgery, and the surgical options currently available the microlumbar discectomy, then the tubular discectomy, and then the uniportal biportal. So what we will discuss and move forward is with the full endoscopy, that is uniportal system through the interlaminar approach, and it can be termed as FELD, full endoscopic lumbar interlaminar approach. And you have the transforaminal approach for this, but then we will discuss the interlaminar approach. So unlike the transforaminal, we need CA mostly because we are behind the dura and the root, so it will be discomfort for the patient in epidural or local anesthesia. And like the thing, we keep the patient in prone on an Wilson's frame, open up the interlaminar window. This is how so for any new innovation, we need new gadgets. And this is a very smart tube. But a smart tube because see this is we use the Richard Wolf interlaminar system. This is the scope, the end of the scope. You can see the working channel, the irrigation channel, and the optics, all being handled into a single tube. So this gives the space for the uniportal approach. So this is an 7.9 mm tube with a 4.7 mm working channel. So the instruments which pass through this are 2 to 4 mm, and you have a irrigation channel. You can separate the camera port, the irrigation channel, and everything here. So as I mentioned, the 4.1 to 4.7 mm working channel, depending on the scope, and instruments are pretty small, averaging at 3 mm. You have a disposers, there is a punch, dissectors, cutters, and you need a you need a RF cautery to precisely cauterize the bleeding, and there are burrs available with both diamond and cutting burrs with guards all around or without guards, so that you can drill out whenever necessary. So again, the scope is around 7 mm. The angle of vision is 25 degree, and the working sleeves are 8 millimeters. So your incision for a lumbar discectomy or a cervical will be like 8 mm. So any endoscopy requires a cavity to work. So spine doesn't have a cavity as such. So we have to create an artificial cavity. So the sheath we used as a beveled open, which enabled creation of visual and working fields in the area without clearly anatomical preformed cavity. So the beveled edge I will show you. So this is how you hold the scope, moving in and forward. You can zoom in and zoom out. For a lumbar discectomy, the sheath is very dock in the midline. I mean, midline of the interlaminar window. Alpha is when you have a wide interlaminar window, and go as medial as possible, and then you go laterally and find out a bone. So this is the sheath you will see. The sheath has a beveled opening, which helps the creation of a cavity-like structure and helps in your uh, surgery. So once you dock, remove the muscles, remove the soft tissues, and you see the flavor, you use the cutter and create an opening in the flavor. Go laterally till you see the root. That's the root and the epilobe are visible. Now, once this is visible, you can go for you can take it out of the 1 mm hooks are there, 1 mm side angle hooks, and you can then take it out, take the disc out with the disc process. So it's a basic procedure you can start with for a full endoscopy, lumbar discectomy L5S1. It's more ideal for L4, 5, L5S1 to go transforaminal, and you can remove large chunks, just conforming with the CM. And fourth procedure, can you can use the seat as a retractor to go for any medially missed bulges or disc fragments. You can appreciate the root. You can remove the disc, but then to make sure that there is no fragment left medially, you can use the sheath itself as the beveled edge tracks the root, and you gives a wonderful vision of the disc face, and you can remove that remaining disc material. So again, inspecting for any left out fragments, you can appreciate the root. So in L45 disc, you need in 5 you'll almost always never drilling the medial facet. But then with L45 you will use a bar, and like this you can drill the medial facet. There's guards all around, and if you're confident, we can use without guards, which helps widen the space for you to work around. So that was about discectomy. Now this is a case again. If a patient came with pain in the right gluteal region, and we felt that the patient had S2 radiculopathy. And this is what is MRI looked like. There was a small LPS on this. But more importantly, there was a Charlosis in the S1, S2 space, which was causing more symptoms because we felt it was more of S2 radiculopathy rather than S1 radiculopathy. So this is the cyst in a basic. This is another pathology we addressed through the full endoscope. You can appreciate this. This is after removing the flava. You can appreciate the Charlosis. And we did marsupializing. And since we are confusing, we did alpha S1 discectomy also for this patient. That was just after removal. So similarly, this is just a short video, just to show how the hook is being used to pull out the disc from the shoulder. And then you can remove it with the disc process. So as I said, this is a just basic procedure to start for a full endoscopic surgery. And even large chunks of this can be removed through this 8 mm incision, because you will have to take the scope and the sheath along with it to get the large chunks out. This one large chunk being removed because it is not retrievable to the sheath. And this is another thing, maybe you'll have to, the 8 mm incision may not at times be enough, but then your general surgical techniques may come in handy and you can remove it. That's again a large chunk being removed. So another scenario is a patient presents with you with neurology complication and the scan looks like this. Again, for this scenario in full endoscopy, you go with a larger scope. I mean, you need to address a wider area. Large in the sense it is just 1 centimeter and 1 centimeter scope. That is the stenoscope. Earlier we were using the interlaminar vertebral scope, but now you are using the stenoscope, which is 1 centimeter, and you need drills and everything. And you can do a canal decompression. This is the poster picture of a canal decompression. You can appreciate the ipsilateral side, the ipsilateral root. And that's the contralateral side of the contralateral root, which the canal being fully decompressed. Now this is one poster picture. This is the post and endoscopic pre and post month. You can appreciate. So another case is so this is again a foraminal stenosis L45. There is lesion at the surface. So this can't go along with this, but then full endoscopy, the laminar technique can be used for final fusion also. So for final fusion, you put in the percutaneous screw as in a minimally invasive lift, and then you start addressing the triangle, taking out the IAP, that is inferior articular process. Here you can appreciate the lower lamina, and you drill out from here to the parts. You appreciate the parts here, and then use an annular tom or a small dissector to get the IAP out. The IAP can be removed as a chunk of bone for purpose of autograft, and this is how the IAP is being removed. This is due to the 1 centimeter incision using the stethoscope. So once the IAP has been removed and the SAP drill, this is the Campian's triangle. That's a displace. You can appreciate the exiting route here, L4 route here, and you can appreciate the traversing route here, and you identify the Campian's triangle. Once you identified this Campian's triangle, you can start your discectomy proper. This is doing the discectomy and the press of the bed for the fusion buffer. So once the discectomy is done, the scope can actually go inside, check for the end-plate cure things, and unlike in a microscope, you can go inside the scope, inside the space and things. And this is how the cage is inserted. So here, what we do is this is how the cage is being inserted, endoscopy cage. But then mostly endoscopy surgeries, full endoscopy, the cage is inserted blindly. So what we have designed is we go through the we keep the scope through the main port and go through the opening for the percutaneous screws. We introduce the cage. So this helps us in viewing the traversing route and helps to keep it safe, and we can boldly enter keep the cage inside the cage. So once you have kept the cage and you look for it is well placed and all, that's a cage inside in situ. So this is how a post-op incision will look like. For the percutaneous screws and the midline, just the parameter midline incision for the decompression and the cage place. That's an endoscopic placed cage. They have narrow cages available for endoscopic cages. So that was lumbar spine, and coming upward to cervical spine. So cervical spine, neck pain radiating to left forearm. Again, we use the technique of full endoscopic posterior cervical foraminotomy or discectomy. almost always we could do a discectomy along with the foraminectomy. Just for this, the views, different views through different, this is microscopic tube, and when you put an endoscope through the tube, and this is the last one is the full endoscopic tube. You can see the difference in the, you can appreciate the clarity and differences. One thing I forgot to mention is that we use the water, so normal saline as an irrigation medium here. So this normal saline as irrigation medium has many advantages in the sense that it washes away the debris and keeps the feed clean. The continuous fluid pressure helps in cutting down the vascular, helps in hemostasis, and allows us to work without much blood filling the cavity. And this continuous irrigation, they say, is, keeps our infection rates also low. So again, just like an tubular PCF, that is an MI-PCF, you do a prone, GA, shoulder strap, reverse and lumbar, Mayfield, and slide flexion. Slide flexion helps the roots to put to the upper side of your foramen so that you get some working space for your ablating the cord and putting us this forceps in and taking a bits. So where do you stab? You mark the medial pedicular line, and then sagittal you do a slanting X-ray, and then get this in the point where they meet is your entry point. You should do everything under Siam guidance because even a 10-degree or a 5-degree change in angle will make you get into the wrong level. So keep everything you do, you just put the stab incision with the knife under the Siam guidance till you reach the fascia. It gives you more confidence that you are in the right plane. So this is one thing. This is I think you have 2, 3, 4, 5, 6, 7 discs. 6, 7 discs. You can appreciate them up. The lateral disc to the left, and you have entered the UCH muscle. You're looking for some bony landmark to get you some confidence once you get a bone. And the first thing is the V point. V point is where so we do a bit of banding with the sheath to get the muscles out, and you can appreciate the V point. V point is where the superior lamina and inferior lamina and the facet joint meet. The V point should be your first landmark for a full endoscopic PCF. The V point is coming to view. And that's the V point. This is, you can appreciate the facet, the superior lamina, the lower lamina, and you can appreciate the flavor in between. So once you have appreciated the V point, you can start the drilling from the superior lamina. Or if you're confident enough, you can start with your, there are some punches, specially designed punches. You can widen the foramen. You can drill with your drill guards all around, widen the foramen so that you get enough working space to retract the root. Minimal retraction of the root, get the disc. So this is drilling the SAP. You widen the foramen, then you remove the phlegm. You can start appreciating the fecal sac. So once you have removed the phlegm, you can appreciate the fecal sac in the midline, the phlegm being cut. You need a little bit more. All these venous processes usually cause bleeding when we are doing an MIPC, but the fluid pressure to an extent helps in controlling the bleeding. That's the disc bulge, that's the fecal sac, but we are not visualized the root. So we have to visualize the superior and the inferior part of the root before we start the discectomy. That's the RF being used to cauterize the epidural vessels. And you remove this, after cauterizing, you can remove the soft tissue and the whatever is obstructing your view. You can appreciate the root now. You're clearing the root, the better vision. See how clearly you can appreciate the vessels and the bleeding, and you can with the RF to pinpoint the vessels and cauterize. So this is again. So very minimal use is one advantage of FEPCF over MIPCF for any surgery. Now we can appreciate the root. We need to get above the root before we start our discectomy. So we have widened the foramen. We have seen the good amount of root. So we go about thing and we take the disc out. So even for a cervical disc, this is a large chunk. Remove the disc, but still we feel that the root and the thecal sac are not fully lax and not maintain their anatomical, the round structure. So we doubt they are with the fragment, and we were rightly so. There's another of those large fragments being. So post procedure, I mean, your field will look like this. You can appreciate the fact the relaxed root, the cavity where there is first present, and you getting hemostasis and you take it out. So again, this is a 2-level PCA treatment. You can see the 8 mm incisions for the 2 levels. So you can widen, if you are confident enough, you can widen your armamentarium full endoscopy to cases like this where it's octogenarian patient where you have multiple level canal stenosis. And you can do, here you can use a stenoscope and do multiple level decompression, and that's the post of MRI and the recurrent optic. So why full endoscopy? Obviously for the less collateral damage. I mean, of all the posterior approaches now available, I think full endoscopy has the least collateral damage. And of course for the magnificent optics it allows. And of course for the front card being the fluid irrigation, which I mentioned, helps you feel clean and the bleeding less. Yeah, that's it. So when you compare traditional spine surgery and full endoscopy spine surgery, this graph explains that there is an endoscopic benefit zone which needs to be tapped, which for complex cases maybe they meet at the end. That is an endoscopy benefit zone we should all notice to tap upon. For any new innovation, I believe this Gartner hype cycles holds good in the sense that there's a technology trigger followed by a peak of inflated expectations, and then there is a dip where you call that raw disillusionment. And then there is a slope of enlightenment. And I feel that this full endoscopy surgery in our country is in the slope of enlightenment, and before it becomes fully utilized, and then there will be a plateau of productivity for the sake. Thank you. These are the various institutions. Thank you.
Thank you, Navas, for this nice presentation. Is there any question? Thank you. And now we will shift
Thank you.
to next speaker, Professor Atul Goel. Please start sharing your screen.
Ramesh, can you ask somebody to stop sharing the screen? Yeah, now I think. Okay, so are you ready, my dear Samay?
Looks good. Looks good.
Okay. So I'm going to talk about facet distraction spacers. Facet distraction spacers. So we described these spacers for the first time, and you know many spine surgeons in the world are now using these spacers. They are particularly more popular in craniovertebral junction, but also they are becoming popular in the cervical spine and in the lumbar spine. So facet distraction using these are the spacers that we described 25 years ago. So this is a 25-year-old long journey of evolution of revolution in spinal fixation techniques. So this is a recent editorial by me. So I will briefly discuss about some other issues, related issues on spine surgery. We have, as you know, we have talked about compression, that compression is never primary. Compression is always secondary to segmental spinal instability. Compression is secondary, it is protective, and it is potentially or manifestly reversible following stabilization. And this very huge concept in spine surgery that we introduced and that we believe and that we are convinced is the future of spine surgery is that decompression is never the treatment. So this is quite a huge revolutionary statement which I am making, but whatever I am saying is whatever I believe. So briefly, I will touch on the concept of central or axial, atlantoaxial instability. And this concept is taking firmer ground in the field of craniovertebral junction. And we have said on several occasions that central instability is the cause of basilar invagination, Chiari malformation, syringomyelia, and things like that. I'm also going to touch on the previously discussed concept of vertical facetal instability. And we have said that this is the point of genesis of spinal spondylotic disease. As I have talked about on several occasions that human body is different, we stand on two legs like no other animal on the planet. All our muscles are focused on the facets. In the craniovertebral junction is a very beautiful, dynamic, and stable concept of craniovertebral junction, where we said that craniovertebral junction is the center for mobility and center for stability. There are two major joints here, occipito-atlantal joint and atlantoaxial joint. Occipito-atlantal joint is the center for stability. Atlantoaxial joint is the center for mobility. Atlantoaxial joint is also the center for instability. And we have talked about how the facets regulate the entire movement of the spine, not only in the craniovertebral junction, but also in the subaxial spine. So atlantoaxial joint is the center for mobility and center for instability. And craniovertebral junction instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. So many of you, maybe those who are doing craniovertebral junction know this technique. Introduce the screw in the facet of C1, facet of C2 through the pars and pedicle of C2. This technique is, as you know, is quite a popular technique. So we introduce screws in the facets of atlas and facets of axis, and they provide a very strong purchase to the screws because these are the strongest points in the vertebra. So my technique since 1988 involves opening of the joint, introducing bone graft in the joint, and then doing C1, C2 fixation. So this is the technique, dislocation, reduction, fixation. Then we introduced a concept of distraction of the facets. And we introduced intra-articular spacers for C1, C2 in the year 2000. So 25 years ago, we introduced these spacers and we said that these spacers can form a primary form of treatment or a standalone form of treatment without additional screws or facet screws or wires. So these intra-articular spacers we call joint jamming technique. We introduced this technique in the year 2000. So these are, you see, there is instability and we have put just spacers and we have stabilized without any other additional tool. This is joint jamming technique. This is another very huge basilar invagination we introduced. This was actually the first case that we did in the year 2000. We had different kinds of spacers And we did this. You see, there is incomplete reduction, but there is significant reduction. More than anything else, there is stabilization. So these spacers have now become very popular in craniovertebral junction surgery, and many people doing craniovertebral junction surgery are using these spacers. So these are my spacers of different kinds. You see, this is one spacer of a subaxial spine where we introduce these spacers, and there are holes here for these screws. This is another spacer where we have holes in the spacer, and we put some bone graft inside the spacer, one screw here and one screw here. So this is another kind of spacer. So these spacers for atlantoaxial joint, there are, you see, over the years, for 25 years, my whole concept in joint stabilization has changed, and our indications for atlantoaxial spacers have now a little bit limited. And this is one paper where we said when we should use these spacers. This is one indication. You see, this is vertical. In extension, it is reduced. In flexion, it is gone up. It is like a piston. I call it vertical mobile instability. Introduce the spacer, and that is the treatment. We all know how we modified the concept of fixed dislocation, where we introduced spacers in the year 2000. Our first case for this kind of fixed dislocation, the whole world was doing transoral decompression. We introduced spacers and then did fixation. We said that there is nothing like fixed dislocation. We introduced intra-articular spacers for such reduction, fixation, and the whole world of craniovertebral junction surgery changed from decompression to realignment and stabilization. So this word realignment was a very novel concept in the year 2000, so 25 years ago. We did distraction, manipulation, opening of the joint, and introduction of spacers for various indications, including this kind of disruption of the facet. We introduced intra-articular spacers for rotatory dislocation for the first time in the literature. So this was our article where we talked about how opening of the joint, introduction of spacers, and manual manipulation of the facets can change the dimensions of the radiological imaging and of the patient's clinical dramatic. You see, this patient has unilateral facetal malalignment, and we have introduced quite a large spacer, and the whole thing has changed, and this is the spacer. Odontoid process is here, and now the odontoid process is in the midline. You see, this is another case where we introduced intra-articular spacers long time. For basilar invagination, many of you know how we completely revolutionized the treatment of basilar invagination by distraction, reduction, fixation, by introducing, you see, these kind of cases were treated by decompression, but we said that distraction, reduction, realignment, initially we used to do spacers for all these cases, and then fixation. So this is another case of basilar invagination where we have completely demolished the art of decompression by a transoral route or by foramen magnum decompression. So in 1999, we said that basilar invagination is listhesis of C1 and C2. Listhesis, this basilar invagination, listhesis is the problem. Distraction, reduction, and intra-articular spacers and reduction. This is the way we used to treat basilar invagination. Now my use of intra-articular spacers is not so frequent, but this is what we introduced several years ago. Then many of you know of my concept of central instability and how chronic atlantoaxial instability can be the cause of basilar invagination, Chiari, syringomalia, short head, kyphoscoliosis, and things like that. So this is listhesis of C1 and C2. open the joint, distract, introduce spacers, or at least bone graft, realign and stabilize. Type 2 is even when there is no atlantoaxial instability. 2, this is facet of C1 is behind facet of C2, open the joint, distract, reduce, and stabilize. So this is another, of course, chapter. Many of you have heard me talking that presence of Chiari, Syrinx, assimilation of atlas, platybasia are indicators of unstable spine. Stabilize, you may or may not introduce spacers. So look at the facet and stabilize. Basilar invagination, Chiari malformation, syringomalia are all children of atlantoaxial instability. And we have produced several articles on the subject on more than 1,000 patients of basilar invagination treated by these kind of issues. So Chiari and syringomalia and basilar invagination, whether you would like to introduce spacers or not, that is another chapter, but stabilization is the key. Now I want to go to another historical concept. Facetal instability is the issue. For craniovertebral junction, osteophyte formation, reduction in the joint space, buckling of the ligaments, they are second. Osteophyte formation, tip of the odontoid, behind the odontoid are secondary to vertical instability. Bulging of the disc, reduction in the interbody space, osteophyte formation, bulging of the disc are all due to facetal listhesis or vertical facetal listhesis. Instability is the issue. All these compressive issues that you are seeing are secondary. They are all secondary to multisegmental instability. They are all protected and they are all reversible. So this kind of stenosis, this compression looks dangerous, but this is not the issue. This indicates unstable spine, and we introduce this concept of vertical facetal instability. Retroodontoid pseudotumor is due to vertical instability. It is like an osteophyte or craniovertebral junction. It indicates vertical instability. Stabilization is the treatment. Any kind of decompression is negative. And this has changed the whole scenario for retroodontoid pseudotumor. Even retroodontoid cyst is secondary to vertical instability. You don't need to remove the cyst. You need to just stabilize. This kind of cyst in the presence of unstable craniovertebral junction, it is negative to treat the cyst, just stabilized and cyst will disappear. Retroodontoid pannus, for the first time we used intraoperative distraction and introduced spacers. And for this kind of pannus, immediate postoperative regression of pannus is possible. And many of you know these articles have completely changed the treatment for rheumatoid arthritis. And this was the first case that we used intra-articular spacers. You see this spacer that you can see? Reduction and complete change. And this was another case where for rheumatoid arthritis and pannus, we used intra-articular spacers. For the subaxial spine, I'm using spacers for more than 2 decades now. Nobody in the world has ever touched on spacers for subaxial spine. And we have said, like craniovertebral junction, instability at the facetal articulation is the point of genesis of degenerative cervical spondylotic myelopathy. So facetal distraction as the treatment of single and multi-level cervical spondylotic radiculopathy and myelopathy. So this is a complete revolution in the treatment. In my own journey of degenerative spine, I think this forms a very strong threshold in my career on degenerative spine. And this article we wrote with a spacer in Journal of Neurosurgery in the year 2011 on the cover page of Journal of Neurosurgery, where we introduced intra-articular spacers. So facet is a strong point of the spine. It is the strongest part of the vertebra. It is the focus of all the muscles of the spine. And we did several articles on the anatomy of the facets of the cervical spine, of the lumbar spine. And you see there is instability at the facet. You will not recognize this instability. You will recognize on the demonstration of osteophytes, ligamentum flavum buckling, and things like that. So you see this case, there is a big osteophyte here. What you do not see is the listhesis at the facet. You do not see listhesis. You see an osteophyte. So ACDF and all kinds of decompressive modes is the treatment. We all know that. There is no question. But what we have done here, we have introduced an intra-articular spacer, distraction of the facet. You see how a new disc is formed. You see how the ligamentum flavum buckling has, this buckling that you see is completely finished. And most important is, there is no decompression, there is no disc resection. This is such an easy operation and such a quick operation. More important than easy or whatever is that it is the philosophical operation. Listhesis is the issue. Instability is the issue. Decompression is a negative operation in my view. So over the years, we have done several cases, and some, as I have already spoken on several occasions nowadays, I don't use spacers very often. I use only fixation, which I will briefly touch later. There is, you see, this is the disc space reduction, bulging disc. You see a new disc formation. Distract the facet. There is increase in the disc space. If you carefully see this space has increased. Intra-articular space, which is reduced preoperatively, has increased. Ligamentum flavum, you see interlaminar space has increased, so ligamentum flavum has become taut, and so there is no compression. This is immediate post-op after patient has come out of the operation theater, and the whole scenario, the entire thing. So what we have not done here, we have not removed any bone, we have not removed any ligament, we have not removed any disc, we have not removed any osteophyte, and we have introduced these spacers in the intra-articular space, and a complete new patient has been introduced. You see this another patient, multi-segmental. The traditional treatment for decades has been to do decompressive laminectomy, which still forms the gold standard treatment. You see these bones, and this is also, you see this is immediate post-operative period. Multiple spacers have been put, and these are in addition to spacers, we have introduced bone graft, no decompression. And what I have to tell you is a completely symptomatic, dramatic recovery in these cases. Dramatic. Of course, I don't have time to show you, and many of these patients. This is another case of OPLL. OPLL, what for OPLL you will do? The whole world still does decompression for OPLL, despite my hundreds of presentations that OPLL is a manifestation of unstable spine. We used to do these kind of intra-articular spacers for OPLL. I don't do them now, but this formed, in my own mind, a complete new understanding of the concept of OPLL, concept of single-level degeneration, concept of multi-level degeneration. This is simple single-level degeneration. I did this operation 20 years ago without discectomy, without any kind of laminectomy, without any kind of sophisticated tool or anything. Just distract, and you see this disc has disappeared in the immediate postoperative period. And I wrote about this. I don't see this, that article here. Immediate postoperative disappearance of the disc after distraction. What we do is, what we aim for is, it is unstable facets. Listhesis is the problem. Stabilization and arthrodesis or fusion is the treatment. No decompression. Decompression, in my view now, is a completely negative and a historical operation. So neck movements will, of course, be limited after this operation, but basically not much movement disturbance is there. Of course, if you do 3-level, you have to have some kind of movement. But the concept is that direct removal of the disc, direct removal of the ligamentum flavum, direct laminectomy are not necessary. What is necessary is distraction, reduction, fixation, arthrodesis. As I have mentioned, nowadays, I don't use too much of facetal spacers, but this is what we had described. So this multi-segmental degeneration, and you see after 2 years, the entire scenario of the spine has changed. And if you realize this picture, there is not a spicule of bone which has been removed, and there is bony fusion in the same case that you saw earlier, this patient, there is bone fusion on this scan, and these are intra-articular spacers. This is a different understanding, different kind of thought process. This is another case where there are multiple. This is preoperative, and you see this is immediate. This is after 6 months, and what we have achieved is stabilization, arthrodesis without any spicule of bone. And what we have talked about is all these osteophytes will eventually disappear, and there is no question. This is another case of osteophyte. This is the stabilization after 1 month. This is a new disc formation, distraction. If you carefully see each of these images, and you will have all this, Samay will be posting all these images on videos, you can see them carefully. If you see the disc space here, they see the disc space has increased. If you see the disc space here has increased without discectomy. So this is what is a completely different version of spine surgery that we introduced about 20 years ago. And this is for you to see, you to understand, and if possible, you see the reduction in the disc space, and you see the increase in the disc space without any kind of discectomy. And what I have done is I have not done any discectomy, any laminectomy, any ligamentum flavum removal, and a magic is the clinical outcome. A magic, believe me, a magic that you have not ever seen with all kinds of decompression that you love so much and you do so much. Not only you, the whole world is doing. And my feeling is the world has to change, and the world will eventually change. I have no doubt about it. Now carefully see this. I cannot show you but see this ligamentum flavum buckling. And you see this is immediate postoperative. If you realize the ligamentum flavum buckling is gone, if you realize the bulging disc has gone, if you realize the disc space has increased and there is water in the disc space, new disc formation, without touching the disc, without touching the lamina, without touching the bone, you introduce a new kind of concept that decompression is not the treatment. If you carefully see this slide, you will realize the beauty of this, that the whole story has, that decompression is not the treatment. Stabilization is the treatment. And this is another case from C2 to C6 or C7, which I have done. Carefully see this slide. New disc formation, new water formation. Bulging disc has gone, ligamentum flavum bulging has gone, and this is what you see in the immediate postoperative period, a magic that you have never seen. Immediate postoperative reversal of disc herniation. This is the same case which I showed you. This is immediate postoperative period, and that was published in Journal of Neurosurgery. This is another case, bulging disc, immediate postoperative finishing of the disc. So this is, and I want to quickly show you a video if possible. You see how unstable it is, how vertically unstable it is. In this situation, decompression in this kind of instability is an absolute negative operation. No matter whole world is doing or whole this fellow is doing or that fellow is doing. I don't want to negate or argue on those things. But what I'm showing you is what I'm showing you, and what I feel is this is the future of spine surgery. And if you realize this is not only fixed, but it is also distracted. If it is distracted in a way that you cannot imagine. You see this another one, I will want to quickly show you. You see how unstable it is. This one is becoming a little more stable because there is a spacer here. You introduce this spacer and you introduce a magic in this patient. So this is a newer concept of intra-articular spacers, which you have to understand. You understand the concept, You understand the philosophy. Technique, this is anybody can do in very, very quick time. And timing, of course, is not the issue in our business of spine surgery or any kind of surgery. What is important is our understanding of philosophy. So this is multi-segmental spacers that I have used. Carefully see, this are also very immediate postoperative. This is delayed postoperative. You see the fusion. You see this is preoperative. If you carefully see this slide, you see the joint space have increased. The interlaminar space has increased. Bone fusion has occurred. More than anything else, these bulges have disappeared. Ligamentum flavum bulges have gone. And this is a new spine, of course. So this was an alternative hypothesis that we introduced in the year 2010. Facet distraction spacers as treatment of degenerative spine, an alternative hypothesis. Facetal distraction, can it revolutionize spine stabilization? My understanding is absolute. So these are the spacers that we introduced, and these are all my patented products. I have patented it. More than 25 patents are there of mine, which you can see. India, there is all these spacers are patented. We have studied this design, symmetry, and spacers in various trajectories, in various biomechanical studies. We have used these spacers also in the lumbar spine and for lumbar canal stenosis. Lumbar canal stenosis, it is not a stenosed canal. It is an unstable multi-segmental. And we published this paper in Journal of Neurosurgery 12 years ago with 21 cases with distraction and spacer. So this is in the Indian mythology, this lady with a very big kyphus, and he is the god of Hindu mythology. He did this distraction. He made her to stand. You see his leg on her feet and hands on her chin, and distraction. Similarly, in Egyptian, in Greek, this kind of gravity traction has been quite popular. This is also from some mythology where he's putting his feet and giving traction. You see there is traction on the bed, and this is additional traction. This is from, so this is a relevance of this hypothesis in degenerative. So these are, now I'm working on another concept of spacers where I'm introducing movement. So there is a joint here. You see, there is a ball and socket joint, and there is a possibility of movement. So there is an artificial atlantoaxial joint using these spacers. These are also my patented product. And these are my models, which I have introduced in the literature already. So you can go through these articles and see these ball and socket joint with different kind of spacers. So decompression has been the treatment for several decades, but now I'm seeing even spacers have to be very selectively used. What we have to do is we have to introduce fixation. So instability is the cause, and all the statements which I am making are very heavily published. Don't think these are artificial and these are just thoughts and these are just speculation. So only fixation using spacers and transarticular fixation, all the osteophytes will disappear in very quickly. This multi-segmental degeneration, you see the osteophytes have all disappeared. Only transarticular fixation and spacers wherever you think that the instability. So we should look at degenerative myelopathy in a different perspective. You have to include atlantoaxial joint in your fixation construct. Similarly, lumbar canal stenosis, this is a neurosurgical focus, the role of stabilization and futility and negativity of decompression as treatment. So this kind of lumbar canal stenosis, the whole world will do decompression, but there is a possibility of doing only fixation using. So these osteophytes will eventually disappear. You see this patient has been treated with spacers and with screws. And if you realize how the whole story, has changed without a spicule of bone being removed, without a spicule of disc being removed, no osteophyte resection. So this is a new concept and osteophytes will eventually disappear. See these spacers, multiple spacers, and the osteophytes have disappeared. And if you carefully see, of course, there will be fusion that we want to achieve, and that is the aim. So even in OPLL, this is a different world of treatment. Decompression is not the issue, stabilization. So thank you very much, my dear Samay. I hope I have been able to introduce some beautiful concepts for you and for the viewers, and I hope you have enjoyed them, and I hope you have loved them. Thank you very much.
Thank you, my dear brother, Atul Goel, for this excellent presentation. Is there any question?
The king has spoken.
John, I cannot believe if there are no questions, because this is a complete new dimension to spine surgery, completely different world. And if nobody has questions, then either they are afraid to ask, or they have not understood, or I am not sure why there is no question, my dear John.
You need more time. The king needs time.
Yeah.
Okay, I have two questions, my dear colleague, my dear professor, if you allow me to. My first question about OBLL. Do you have the same procedure for OBLL, or it's another?
In OPLL, you know what? Now, Samay, you are a young neurosurgeon, okay? And you have to be open in your mind. You cannot be fixed in your mind. You cannot be fixed. And if somebody is giving you some concept, you have to think about it. Okay, Samay? You promise? You promise?
Yeah,
Now
sure.
for OPLL, the whole world is doing decompression. You agree? You agree? You know
Yeah.
what? I introduced oblique corpectomy for the first time in literature for OPLL in 2004. This is my paper. First time I introduced oblique corpectomy. Many people in the world are doing oblique corpectomy now. But as I grow further in the business of spine, my concepts have changed. And I have done some cases even in Egypt. You may not know, I have done some OPLL even in Egypt by only fixation, no decompression. Most important issue is in OPLL, you have to identify which levels have to be fixed. It is not just OPLL level. You have to, that is the most critical issue. You have to do fixation and no decompression, and that is the treatment. You must, whoever is doing OPLL must read some of my articles on the subject. This is my suggestion, my request, not only for us, for our patients.
Okay, thank you. Second question, if we hammering the cervical spine from posterior, there's nothing to be supported from anterior. Did you have experienced any worsening of cases because of this, or nothing?
I will tell you another thing. I introduced tricortical screws to the vertebral bodies for the first time in literature. I was doing a lot of anterior fixation for a long period of time. But facets, if you touch the vertebral, if you have vertebra in your hand, vertebral bodies are the weakest part of the vertebra. You touch, you put your, you try to tap it. The vertebral body is the weakest. And you know which is the strongest part of the vertebra? The facets. If you fix the facets, it is much stronger than fixing the vertebral bodies. So I now do only fixation of the facets. Vertebra is a very flimsy. Putting screws in the vertebra and putting cages and all is a nonsense operation in my view.
Thank you.
I mean, enjoy it. And if you like it, take it. And if you don't like it, ignore it. Okay?
Atul.
Yes.
Thank you.
Atul.
Go ahead.
Yes, sir.
Go ahead.
Yeah. Go ahead, Harsh.
Atul, we are all convinced by your methodology of fixing and stabilizing the facets. We have fully understood the vertical facetal instability. And we have experienced ourselves by after seeing you doing it, and we have done in our patients, and patients have done well. So there is no second thought the people have to learn. It is basically you have proved it beyond the point.
Thank you.
I must admire you for changing your views and negating your own paper of 2004 for an oblique corpectomy and saying, no, don't do this, do this. So you have a guts to say.
Thank you.
Because you
Sir.
have a mind, open mind to improve yourself and to improve the others. Because as you said, keep your mind open and learn.
Yes.
You are a great thinker. You are a great thinker.
Thank you. Varsha.
I second that. I second that.
Thank you, John. Thank you.
Thank you,
Professor.
Okay,
Thank you,
Sam.
Professor.
Okay, Sam.
Thank you, Professor Atul, for this excellent presentation and for nice discussion. Thank you. And now we will shift to next speaker, Dr. Achal Gupta. Please start sharing your screen.
Hello, Dr. Samay. See, am I audible?
Yeah.
Yeah,
Yes.
You want to make a presentation mode, please? Make it presentation mode.
So after the electrical presentation of Professor Atul Goyal, it's really very difficult to fit into his shoes. But let me give my try. So many congratulations to you, and many thanks. I'm thankful to John and Dr. Samay to give me this opportunity. Today I will be speaking on the shifting paradigms, the growing. Am I audible?
Yeah.
Yes.
Yeah, the growing role of endoscopy in the spine care. So, I'm not able to change. Yeah, so I'm not able to change my slide.
Okay, stop sharing and reshare again.
Okay, where is my slide change? So I can't. They are not okay. Stop sharing. Before I started, I joined this. I checked myself. It was working well. I don't know.
Okay.
Yeah.
Start sharing
So okay. Now this is working. So before I talk about my topic, I always remember my teachers and the mentors, Professor Ramani, Professor Turgoil, and Professor Lim, who introduced the spine concepts in me. And
we don't see your screen.
Okay, sorry. Okay, sorry.
It fell off. It happens.
Okay, let me reshare.
Okay.
Is this okay? Now, can you see my screen?
Yeah.
It's not presentation mode yet.
Yeah, presentation mode is working.
Okay,
so
perfect.
Okay,
perfect.
It's working. Yeah, it's working.
Yeah.
So now today my topic is shifting paradigms, the growing role of endoscopy in the spine care. So before I touch upon my topic, I always remember my mentors and the teacher, Professor Ramani, Professor Goel, and Professor Lim, who introduced these spine concepts in me and taught me the spine. So the history of the spine surgery started in 1829 when the Smith introduced the lumbar laminectomy for the discectomy. In 1925, almost 100 years later, cervical laminectomy was done for the discectomy. So in 1952, PLIF was introduced by Clover. Later, the ACDF was introduced by him. See, in 1967, first lumbar macrodiscectomy was done by Yasser Gill, which became the gold standard. The first attempt of percutaneous procedure was made by the Magrel when he put the pedicle screw, and the later endoscopic discectomy was done by the Cambins, and Cambins worked. Cambin introduced the Cambin triangle. In 1993, percutaneous facet fusion was introduced by the Wang, and microendoscopic discectomy was introduced by Foley in 1997. Fully endoscopy SCDF was introduced by the Rutan in 2008. See, a lumbar decompression in the form of laminectomy was done day in and out, and we can appreciate the Christmas tree pattern of the traversing nerve root in which they are decompressed very nicely. So this is a lumbar macrodiscectomy, which was first done by the Yasser Gill and very much propagated by Professor Ramani around the corner of the world, teaching the students. So where there is extrodisc fragment was removed under the microscope and the incision was less and the traversing nerve root was set free. So these are the old procedures of the spine fixation where the heart-shield ring fixation was done. Then the facetal screw fixation was done along with the decompression. And then PLIF was introduced, TLIF was introduced, short segment, long segment, all this work was done. So what are the demerits of the open spine surgery that we all know of and we have encountered? First is the wound pain immediate post-surgery when the patient requires a lot of NSAIDs and the opioids to relieve his wound pain. Next is the increased blood loss because of the massive muscle damage and the big incisions, there is increased blood loss. Sometimes they may require the blood transfusion even. There are incidences of the incidental neurotomy. Sometimes they are so big that there are CSF leak from the wound and there are chances of surgical site infection. So in the open spine surgery, there is no doubt when you do decompression, there are more resection of the facets. There is loss of motion segment. As this point is really, we talk very less about it. We open the spine, we fix it or we decompress it, whatever we do it, but we lose the motion segment as we are destroying the muscles, as we are destroying the facets, as we are destroying the paraspinal muscles. So all these things increase the instability, and definitely these dirty big scars always remain on the patient's body. So definitely all these patients requires a prolonged recovery. All of us will correlate with this picture when there is CSF leak from the wound and we have to put the lumbar drain, and the patient is made to lie in prone. He is praying to the god, surgeon is praying to the god that the wound should heal. So now we discuss regarding the evolution of the endoscopy. When the Pervez Camis and Hijikata, they started the percutaneous procedures in the spine. Pervez Camis then described the Camis triangle, transforaminal endoscopy. Anthony Young, Kevin Foley's, Michael Schubert, Thomas Hoagland, and Sebastian Bruton, all of them, they have worked tremendously and they have developed multiple endoscopic approaches and the procedures. They developed the endoscopic instrumentation so that the patient can do benefit. Now, what are the current applications of this spine endoscopy? All kinds of disc herniation, whether it is paracentral, foraminal, central disc herniation, or the sequestered disc, recurrent disc, or the calcified disc. All kinds of stenosis procedure, when there is grade 4 stenosis, lateral recess stenosis, or the synovial cyst formation, or the facetal cyst formation. And in the cases of para-PSLD in the form of or transforaminal decompression in the when there is extra foraminal compression. Endolip surgery for the low-grade spondylolisthesis. Now, even the high-grade spondylolisthesis are being treated with endolip surgeries. Cervical endostenosis or the disc part and spondylodiscitis. Even the spine first drainage is being done with the endoscope. Even the spine tumor surgery. So extradural was being done since quite a bit of time, and now intradural tumor are also being done through the endoscope, and certain case reports are present in the literature. So this is an endoscope, interlaminar endoscope, stenoscope, where the working channel is 5.7 millimeter and the working length is 120 millimeter. Outer diameter of the endoscope is 8.4 millimeter. It means we have to give incision less than 9 millimeter. So this is my first case where there is a disc present at the shoulder. Once we introduce the operator and the working sleeve, we introduce our endoscope, we can see our ligamenta flavum. We do the lateral flavectomy to expose the traversing nerve root. Now we can appreciate the good fat plane, and as soon as we move our cannula inside, we can appreciate this. Yes, we can appreciate this extruded disc fragment as soon as we start to mobilize this with radio frequency ablator probe. It is coming out very nicely, beautifully. So, yeah, this is a micro endoscopic rongers through which we can remove it, and we can see inside there is no further fragments are there. We can do the annuloplasty, repair it well, and can come out. So I want to show you another thing in this case. So this is the extrude disc fragment which has come out once, and now this is a scar which is very minimal scar, 9 millimeters. Sometimes 6 months down the line, the surgery patient also gets confused. Where is the incision where the doctor has operated? This is another case where there is a down migrated disc, and we started. This is L4 L5 level, so we started the same way. We did the L4 cranial laminotomy and the L5 caudal laminotomy to expose the ligamentum flavum to see where there is a ligamentum flavum attachment, and then we cut down the flavum. Later flavectomy is done to see the traversing nerve root. Once we see the traversing nerve root, then laterally at the shoulder, we started looking at the disc, but we are not able to find any disc over here. So yes, then we mobilize, we look around the corner and we see this is present into the axilla. Yes, this is a white corner that we can appreciate very well. So with this, we remove this actual disc fragment, and now we have the endoscopic hook through which we can, these are the endoscopic hooks which we can put inside and see if there are another extruded disc fragment, and we can remove it. So this way we do the decompression, and this is being done under the water irrigation. It helps us in dissection between the different tissue layers, between the nerve root, between the this disc fragment. It really helps us. And further in the last, we can appreciate there is complete decompression of the traversing nerve root and the cord, and the free fluttering of the dura is there. Yeah, it's nicely decompressed, and all the fat is there. There is no minimal scarring. So this is another patient which is suffering from a lateral stenosis. So as we put our cannula, we started clearing the soft tissue. Starts with the cranial laminotomy, and we identify the point where the ligamentum flavum is attached to the cranial lamina. Yeah, nicely now we can see the flavum attachment, and now we started removing the flavum from the cranial lamina. So this is how much that we remove the cranial lamina, do the cranial laminotomy, and we remove the flavum completely and decompress the first ipsilateral nerve root. Yeah, this is nicely done, and this is a ipsilateral foraminectomy that we can do. Once we are done with this, we can do the discectomy. Only the extruded disc fragment, free fragments, degenerated fragments are removed, and annuloplasty is done, and over-the-top decompression is done. So now this is the case of lumbar canal stenosis grade 4. And again, the procedure remains the same, doing the cranial and inferior laminotomy to expose the flavum and its attachment. Once we find the attachment, then we start removing the flavum, do the over-the-top decompression, remove the flavum completely, and this is the over-the-top decompression, beautiful decompression. And in the last, we can appreciate, we can do the annuloplasty if there is no loose fragment. So we can appreciate the pre-surgery and post-surgery MRI, the significant improvement in the cross-section diameter of the cord. So this is another patient. So patient was complaining of left side sciatica, and patient was earlier operated. We can appreciate 2-level lateral stenosis. This is a large scar which is present of the previous surgery. And now this is the para-PSLD approach. We are going the paramedian, and we are directly docking on the transverse process, removing the soft tissue of the transverse process. Then we go a little bit down to identify the isthmus, transverse process and isthmus junction. And then we drill it a little bit, remove the foraminal ligaments, so that we can appreciate the exiting nerve root. This is a beautiful exiting nerve root that we can appreciate. Now we just need to do 360-degree decompression around it. So this way, definitely the patient is going to improve significantly. And most importantly, we are not touching the previously operated scar tissue. Therefore, we are avoiding all kinds of issues like dural rent or infection, risk of infection and everything, and patient is completely relieved. So in the last, I would like to show, so this is a decompression, nice decompression of the exiting nerve root, and definitely the patient is pain-free. And now I'm removing working sleeve. Now you can see, appreciate the healthy muscles over it. So this is the beauty of the endoscopy, and it gives us chance that we can do a nice job. So this is a case of cervical foraminal stenosis at 2 level. The prone position is given, and this I'm showing at C667 level. After clearing the soft tissue, we identify the superior lamina, that is C6, and then we identify the V point. So once we identify the V point, then we start drilling the C6 lamina, making a V to U so that we can widen the foramen. Once we widen the foramen, we can see directly the exiting nerve root and the cord there. So now we can use our nerve root hook to palpate the disc, and we can easily remove. And now we can look beyond the yes. So we can see the disc, and disc is removed. So yeah. Wonderful. So next, this is the next case of synovial cyst. Here we can see very nicely. This is a synovial cyst. This is the ligament of lemon hypertrophy, and patient is having left side sciatica very badly. So now the interlaminar approach, fully endoscopy method is adopted. Superior inferior laminotomy is done, and the phlegm is removed. Phlegm was very thick in the lateral recess, so it was very nicely and slowly, patiently was removed. Then we appreciated. Now we can see the cyst wall down. This bluish color cyst wall, we can appreciate it. Yeah, this is a cyst wall that we can appreciate it. So we first do the annuloplasty, then we take the bite from the cyst wall, and using the radiofrequency ablation, we remove the cyst. So this is how the complete decompression of the nerve root is done, and the patient is definitely free of these symptoms. This is the next case of spondylolisthesis. There is ischemic fracture, which is very much appreciable over here. So once we do the interlaminar decompression, then the transcambin cage placement is shown. Now I am doing the endoscopic T-leaf cage and dual cage placement also. These are my first initial cases. Some initial cases are there. So a nice fixation, patient improved significantly. So in 2017, regarding the RCT of comparison between the transforaminal endoscopic discectomy versus a microdiscectomy, it has been proven that at 2-year follow-up, there was significant difference between the affected side limb, and the pain was less in the endoscopy case. And on top of it, there was less blood loss, shorter hospital stay, and less back pain in the endoscopy group. This is another RCT which emphasizes on the importance of fully endoscopic interlaminar decompression in comparison to microscopic decompression, that there are significantly lower complication rate and the revision rates. So this is a paper which explains about the cervical foraminotomy and the discectomy. It compares the endoscopy posterior cervical foraminotomy is performed for lateral and has a high success rate for the radiculopathy resolution without serious surgical complication. Endoscopic visualization also allows a posterior view of intervertebral disc, as we have seen in my video now, and which is not normally seen with conventional approaches. After the foraminotomy is approached, the nerve root can be manipulated and the foraminal disc condition can be removed very easily. In 2011, open cervical foraminotomy is compared with the endoscopic posterior foraminotomy, and it has been shown that there is an advantage of less blood loss, shorter operative time, and shorter hospital length of stay. So Rutan in 2008 published this study, and in cervical spine, it has been established for the PIVD the ACDF is a negative operation, and the posterior endoscopic cervical foraminectomy has much advantage, as it doesn't require the any implants. So there's no risk of implantation hardware issues later on. And moreover, we are not fixing the motion segment. So in Journal of Orthopedics in 2015, this is the original article published, which compares the treatment of lumbar canal stenosis in obese patient. So they have seen the patients with greater BMI of 30, they have underwent the endoscopic lumbar decompression procedure, showed that they were able to achieve significant improvement in the pain and almost the same clinical results. In contrast, obese patients have a higher surgical morbidity risk and requires a larger incision, larger muscle damage, larger tissue dissections. So this is another paper which emphasizes that mean operative time in BMI more than 30 is shorter in endoscopy as compared to the open macrodiscectomy. And there is another finding: there is no significant difference in the blood loss, recurrence rate, and the complication rate and the length of hospital stay when we compare between the obese and non-obese patient in the endoscopy group. So if the patient is obese or not obese, it doesn't really bother in the endoscopy group, as the steps remain the same. You just go near the target and start doing the work. So fully endoscopic spine surgery diminishes the surgical site infection by how much? It's a significant. It's almost 16 times reduction in endoscopy group. So furthermore, it really decreases the economic burden to the patient if they are suffering with some other issues. So dural tear during the lumbar spinal endoscopy, it has been shown that in the endoscopy group, it is really less. Incidence is less as compared to the open, because of the use of saline irrigation. It dissects between the tissue, and it really helps in removing the target very clearly. And second thing, using the endoscope, it is so magnified and clear, so there are chances of derotely is less. So when we study in 2003, this complication of revision spine surgery was seen. So in the revision spine surgery, it has been proven that there are higher rate of infection, derotmies, and intraoperative complications due to scarred tissue and the dural adhesions. Endoscopic approaches like transforaminal approach and para-PSLT approach avoids this scar tissue and directly decompresses the nerve root by approaching to the untouched tissue that I showed recently now. So complications in the endoscopic spine surgery. This is a systemic review published in 2023. Incident rate is so less, it is just 3.1 to 7.4% for all perioperative complications. The major complications like epidural hematoma, incomplete decompression, or infection, it is as less as 0.8 to 1.8%. The highest incidence of minor complication was dysesthesia, which ranged from 1.3 to 2%, and that also improves in 3 weeks post-surgery. Complications of fully endoscopic lumbar discectomy versus the open macrodiscectomy. This paper was published in 2022. This is a systemic review, and it has been shown it is almost 50% reduction in the overall complication rate. So fully endoscopic spine surgery is the most advanced minimally invasive spine surgery, which is getting accepted as gold standard for lumbar discectomy and decompression. During decompression by endoscopic spine surgery, the aim is to preserve the facet joint and muscle to maintain the stability. Advantages: we have seen we are near the target, so magnification is there. We can look around the corner as the endoscope plays like a joystick, and really we can go around. And there is always an angle to the endoscope, 12 degree or 15 degree. It further helps in looking around the corner, and there is no blind spot. So, and there is less injury to the facet joint, less acute post-operative pain, reduced collateral damage, minimal muscular trauma, and there is very less scarring over the dura because the fat plane is preserved over there. We are just targeting the pathology, and there is no dirty scar, less post-operative pain, and the recovery is really very fast. And now I conclude my talk. Full endoscopic decompression technique has good results and can deal with almost all extradural pathology. Endoscopy is revolutionizing the spine care with its minimally invasive approach, reduced recovery time, and improved outcomes. Thank you, and I'm open for the questions.
Thank you, Achal, for this nice presentation. Is there
Yes.
any question?
No question. Samir, let me just give some
Yes.
compliment to this young man. I think Achal, you have now grown into a different direction. You have gained a lot of confidence, and I send you my best wishes, and I hope you can showcase your work in the coming future in a more profound manner. And my best wishes to you. Only probably I would have liked to see that you stopped the history. You never talked about, you talked about some facet fusion by Wong. I'm not sure if your analysis was correct. Maybe you can show me later when.
Percutaneous. It was percutaneous. We are more, not the open one.
You send me the detail because I cannot believe that somebody has talked about it in the past. Okay, please send me the detail because if this is there, I will be, that direction will be a little different.
Yes.
And also, intrafacetal implants, where you stop the history at a stage when these things have developed. I think you should have continued the history and you should have gone further. In any case, my best wishes to you, and I hope to see more from you and more of you. Thank you, Achal.
Yes, sir. So one more thing, sir. I'm also developing the to put the facet screws, percutaneous instruments so that we can put the facet screws percutaneously, and also the bone graft percutaneously. Already two designs we have been modified, and the third design have gone. So hopefully it should come, and definitely I will show to you, sir.
Okay. Thank you.
Thank you, sir. Thank you.
Thank you, Achal, once more. And now we'll shift to next speaker, Professor Amit Saba. Please go ahead.
Thank you, Dr. Samay, and for providing this platform. And it's been a very good speech from a lot of speakers, well-known and learned speakers. And I'm so much happy that Samay and others has actually made my work easy by talking a lot of the aspects of UBE. What I will be talking about how to employ the scientific principles for safe and effective UBE. I have nothing important to disclose in this presentation. I may be taking some commercial name, but that was for purely education and sharing experience. For those of you who have not been to Nepal, these are some certain snapshots of our beautiful country. You are most invited in the month of November. We are organizing an international meeting, so that will be a good time to visit Nepal. Well, nothing in the business of innovation and industry has actually stood the test of time as the safety pin, which has over the period of 176 years, has still been useful to the humankind without changing its shape. Precisely in medicine, it does not occur. So we all neurosurgeons have been trained through microscopic use in the spine, then we were pushed to the channel-based endoscopy, and now we are doing pure endoscopic approaches to the spine. My practice has also changed gradually over the years. Initially, we had to approach intradural and extradural lesions. We used to go for hemilaminectomy approach, for which I was also awarded, but then we pushed for the air-based endoscopy, where we used a Destando system, a mobile system, to get through the extradural compression of the spine, and we even used this for intradural pathology. And now, after going through a brief period of monoportal, we have transformed into a UB approaches, which I found to be very effective in extradural space creation and disc pathologies. And of course, now we are using a lot of hybrid technique to even attack the intradural and interdural approaches. Well, when I started this approach, there were a lot of fears within me regarding this new technique which has come. This was almost 1.5 decades back, particularly the fear of complication when we are creating a space inside inside an area which does not have any space at all. Then the loss of vision due to bleeding, small field of view because the scope is going inside, so that's why the field of view becomes very smaller. The difficulty in making a depth perception, the pressure it creates due to irrigation, the maneuverability and manipulation. So there are a lot of things which actually create an anxiety when we started to start this thing. But then slowly and gradually, when we started reading this literature and going through this, we found that endoscopic spine surgery is indeed a safe and a tissue sparing and efficient method which Achal has also presented in his talk. He presented of two RCTs which actually have dealt with comparing the endoscopy with microsurgery, and then they found that the patient had a lot of good post-operative recovery. And of course, when we compare from technical point of view, it has not only decreased the local and the systemic inflammation, but also as compared to the MES, it provides a high resolution of access visualization of the surgical field. And that's why it actually makes the surgery much more better. And of course, it gives you an access to the hidden zone of McNape, access to the contralateral side, treatment to various level of foraminal stenosis, cervical and thoracic disc herniation, which was earlier not that amenable through smaller spaces. And of course, whenever you have a patient who had already had an arthrodesis performed, you can actually do a decompression of the nerve root using an endoscope, UV technique, which is very much favorable. And of course, after going through a lot of training programs and after doing a hands-on technique, you could actually achieve a good results. And now not only for the decompression, but also for putting in MIS TLF after decompression, and a patient who had been bedridden and had sarcopenia because of prolonged bed rest, if you can make the patient walk on their limbs, it is almost like a boon to the patients, and you can see the look of the smile on the patient's face. Well, to begin with the principles of how to manage these things much more better, the first and the foremost is to maintain the physics of triangulation. The visualization is very, very important. So you should maintain almost a distance of 2 to 3 centimeter between the scope port and the working port to achieve a good triangulation inside the working space, so that you can maneuver the particular instruments much more better. And one should also learn to use both the right hand as well as the left hand to have the instrumentation stand, so that if you're working on the right side of the patient, you should not feel handicapped in that situation. Then is the use of 30-degree scope. We neurosurgeons are much more trained to work with 0-degree or wide angle endoscopes. But then the problem of the 0-degree is that you are actually only looking at end-on view. But if you have a 30-degree scope, or better, if you can have much more angulated view, the expanse of vision becomes much more better by just rotating the axis of the scope. We do not have to move the shaft. We just have to rotate the axis, and then the whole thing can be actually made beautifully presented in front of it, as shown on the right side of the screen. Then we have to understand that the spine endoscopy, particularly the UBE, is a fluid-based technique, and that's why the media which you're using is a normal saline in room temperature. And a lot of people actually use pump at a pressure set at 25 millimeter mercury. But as a dictum, I always use they to be kept on a height of 1 arm length, because it gives me a safety measure. And then we always like to keep on a much more height, or give some pump pressure only if the ligamentum flavum is intact. The moment we do a flavectomy, we do not give any pressure, because that pressure can be transduced into the intracranial pressure, and the patient can develop a postoperative blindness and headache because of these problems. And of course, one should be cognizant of the ingress of the irrigation fluid, that is, with the port for the scope, which also had the channel, and then of course the egress, the working port, because once your instruments go out, then we can create many false passages. So to have a semi-tubular retractor system can actually help you to prevent severe build-up of the pressure, but also avoid making new spaces whenever you are putting instruments in and out through that one. So the fluid is required because it creates a space by elevating the paraspinal muscles from the working chamber. Because of the constant irrigation, it creates the visualization, improves magnification, and prevents infection. And of course, since we're using the bipolar radiofrequency ablators to clear the tissue off, and of course, the scope which is inside the human tissue, the cavity, the heat it generates can be dissipated by the continuous irrigation. And the irrigation also actually clears the blood and fulgurated tissues. It provides hemostasis, because the pressure itself can actually collapse the epidural venous pressure, which gets collapsed when the pressure rises for more than 15 millimeter mercury. It indeed pushes the dura away from the irrigation fluid and protects it from getting torn by our instrumentation. And last but not least, it creates a media for the plasma radiofrequency equipment. And this plasma is created at the tip of the RFA probe. And this does not allow the temperature to go at a very high level. And you can even do a coagulation on the nerve itself without damaging the nerve, which is the beauty of using a cold plasma RFA. Now, the disadvantage of these fluid in UB is definitely because the fluid is under pressure, it can increase the pressure of the intracranial region and can cause severe neck pain, headache. It can even cause convulsions. Patients have been reported to develop temporary blindness and visual loss following high intracranial pressure. And the postoperative numbness has been seen. Patient develops muscle edema. There can be postoperative oozing of the fluid. So that's why whenever somebody is embarking to go on a journey of UBE, one should always be aware of how to maintain the stable water dynamics. This hydrodynamics is very, very important to create a safe and a complete environment for UB. So the first principle of the hydrodynamics, which we all learn when we were in class 8 or 9, had been the Pascal's law, that whenever there's an incompressible fluid and the pressure is applied to one part, the pressure is equally distributed to all the parts, irrespective of the shape and the volume. The most important thing which matters is the height. So the moment we keep the particular reservoir for the fluid on a height, the pressure is translated, that particular height column actually translates the pressure onto the most dependent portion. And in this case, it is not the operative area, but the patient's eyes, which are on the lowest level when the patient is lying flat, prone on the operative table. So whenever we are actually increasing the pressure, all the pressure is transmitted there. So we should be cognizant of that fact. And this particular pressure is required to maintain the space for the work to make the ports patent. And that's why this fluid management system, which includes irrigation and suction, is very, very important to optimize the surgical environment. And of course, for the hemostasis, as I did talked about. Now, this hydrostatic pressure is very important because it actually creates a very, very less bleeding area, which is very difficult to achieve when you are doing a microscopic discectomy. Many times we have epidural oozes, and these oozes can actually block your vision. So the moment you actually increase the pressure to not more than 15 to 25, this particular epidural wave oozing stops, and that's why the water and also the water media washes of the blood. So this helps create it. But the only caveat one has to be aware of it, that if you increase the flow of the irrigation, it actually just washes off the plug formation. And of course, it can hide the epidural bleed because of its flow. Now, this hydrodynamics has been studied by Dr. Holmes et al. And their team. And they have come up with a beautiful paper in which they have found that the rigid cannulation, the length of the rigid cannulation, as well as the BMI of the patient has a positive correlation with the pressure which is created inside the cavity. And that's why they advise to use a shorter length of tube, as well as in a patient who is having a high BP or BMI to have a lesser of the pressure inside the cavity. Now, the other principle which we should be cognizant about is the Bernoulli's equation, which says that the sum of the static pressure, dynamic pressure, and hydrostatic pressure is constant when it flows, when the fluid is flowing. And this is very, very relevant in our scenario in a UB technique because we have a continuous irrigation going on. And what happens is that the moment we see a blood, we tend to increase the irrigation flow, which actually decreases the pressure inside the cavity, because once the pressure increases, the hydrostatic pressure decreases. That's why it tends to decrease the pressure inside the cavity, and that's the bleeding actually increases more. So rather than increasing the velocity, we can actually increase the hydrostatic pressure to decrease the bleeding. So that is one of the reflex we have to come upon when we are using this principle on the UB. Of course, there are many other devices which are made on this principle, like suction devices, those teardrop shapes of the devices which have been created, the irrigation systems, the instrument designs, and even the tissue manipulations have been using this Bernoulli's theorem. The other principle which we have to be cognizant about is the laminar flow, which is basically important to flow the particles of the operative site. So if you create any turbulence in the flow, these all particles tend to sediment on that place. And one of the most important thing which actually disturbs the laminar flow is the use of the drill. So the habit of neurosurgeon to work on a very high velocity of the drills should be overcome when we are using an UBE. The drill should be operated around 10,000 RPM. That should be far more sufficient enough to drill the bones to make some spaces. And of course, whenever we are pushing any instruments inside the cavity or inside these spaces, we should be aware that we will be destroying the laminar flow. So whenever the patient is having bleeding or we want to wash the area to have a good space, try not to introduce any such instruments inside. Then some scientific principles to use when the bleeding occurs, because bleeding is something which obliterates the vision as the blood absorbs light. And in the panic state, the surgeon tends to use more diathermy and causes much more harm to the patient. It actually frustrates the surgeons and can create a bad result. So how can you use hydrodynamics to control bleeding? Definitely is the irrigation pressure. So rather than increasing the height of the irrigation or using the pump, what you can do is you can just close the egress of the fluid, increasing the hydrostatic pressure in the cavity for some time, and it can achieve a good hemostasis. If it doesn't help, then you can use a pump, or you can actually control the vortex movement of the fluid also to maintain a good hemostasis. But one should be aware that when you are irrigating the whole thing, then the blood loss gets hidden. And this has been studied in one of the paper beautifully, where they have found that this hidden blood loss is underestimated because of the continuous irrigation. The surgeons keep thinking that their patient is having less bleed, but in fact, the patient is having an ongoing bleeding. And this blood infiltrates into the soft tissues and remains in the dead space. And they have calculated this hidden blood loss to be almost 3/4 of the total blood loss. So that's why it can be sometimes very much high, particularly when their patient has been operated over a very long time and the patients have a very thick paraspinal muscle thickness. So these hidden blood loss event should also be considered. Now, to improve upon one's techniques of endoscopic surgeries, there are various new gadgets which are coming up. Like for the depth perception, we surgeons have been using continuous movement of the tip of the instruments, touching the base of the area of work, so as to make a depth perceptible. The other thing which one can use is a use of a 3-dimensional endoscopic spine system, which can actually give a very good depth perception. Then the use of navigation, which has become very, very important in some of the places, and in fact in my practice too, because what we have seen is that endoscopic spine surgeries actually have to have a lot of X-ray exposures, particularly when we are including an NMIS fixation at the same time. So by using a navigation system, we can actually do away with a lot of fluoroscopic exposures to these patients, bringing down the radiation exposure in these patients. So this is another gadget which can be of great help in endoscopic spine surgeries. And of course, when the whole thing is about to give the best possible care to the patient, and as I've also seen in one of the slides of our previous speaker, he was talking about the daycare surgeries. So if in case we can actually club this whole procedure with an enhanced recovery pathway, or ERAS, as they say, the patient can be discharged much more earlier and with least discomfort. And nowadays, people are coming up with the with certain blocks which can actually give a very good post-operative pain relief. So erector spinae blocks have also come up, which can actually give a very good post-operative relief. These patients, making these patients ambulate even after instrumentations on the same day of the surgery, and making discharge possible as a daycare surgery. Now, of course, all this what we are learning may sound theory to a lot of you, but then if you can practice it more often, adopt this particular technique in each of the cases, and of course, the learning curve, which we all talk about in endoscopic spine surgery, it becomes very much shorter. As is this, and this is study by Sharif et al. They have found that if in case the surgeons have this particular proficiency, both in open spine surgeries, minimal invasive, or microscopic spine surgery, then it becomes very easy for them to uptake the endoscopic surgeries with very less amount of number of surgeries required for attaining and proficiency. So to conclude, endoscopic spine surgery has not only prevented instability, but also had made instrumentation a lot more easier with minimal morbidity, and of course make surgeries, redo surgeries, or re-exposure of these patients almost non-needful by using a completely novel pathway. It has decreased the hospital stay as well as accelerated the patient's recovery. One should be cognizant of the ergonomics of the UB, how to place the ports, and how to use the instruments. Hydrodynamic principles for safe conduct should be adopted, and of course to achieve the maximum efficacy of the procedure. And these scientific principles can also be used to achieve good hemostasis during the surgery. And overall, if in case I was aware of the scientific principles, it makes the life much more better and the surgery much more faster as well as efficient. Well, I will invite any young neurosurgeons or the trainees, if they're interested, to our institute, which is at WFNS Postgraduate Training Center, to visit us if in case they want to see how this particular surgery is being done and how to adopt these principles. And I will be thanking you once again for giving this platform and open to any queries. Thank you once again.
Thank you, Dr. Amit, for this excellent presentation. Is there any question? Thank you. And now we'll shift to next speaker, Dr. Mingo Shen. Please start sharing your screen.
Hello, Professor Summer. Can you hear me?
Yes, please go ahead.
Okay. Okay. I will begin my speech.
Okay, you need to put it on presentation mode, please.
Presentation is Shenming Kui.
Yeah, it's at the bottom usually. There's an icon.
Yes. Yeah.
Yeah.
Professor Yang Hejun and me, we are a team from the one hospital.
Oh, okay. Well, you're gonna have to press the slide for every. You're gonna have to change the slides yourself.
Okay.
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 Shen, please press this button.
Yeah, that's true. That's good. That's good. Yeah. One of those icons is the right icon.
Press this
Try
button.
them all. Try them all.
Try more.
You see at the bottom, there's some icons. At the bottom of your presentation, there's some icons that you click on to get a presentation mode.
Like this? Yeah.
Okay, hold on. Okay, now at the bottom, there's 5 icons. Click on one of those.
Yeah,
there you go. Perfect. You got it.
Yeah. Oh, okay. Well, dear conference presents, thank you for your invitation. My name is Shenming Kui, come from the 3rd hospitals of Henan province. Today, the topic of my speech is UB for the TOLIF, because the Professor Yang Hejun and me come from one hospital and one team. So we share this speech for us, for you. This is our hospital's location in China, Henan province, Zhengzhou city. This is hospital's detail. We located in the Zhengzhou county of Henan province. We have 1,800 hospital beds and more 2,000 professional and technical persons. This is our team. Because the minimal invasive surgery is the development trend of the traditional open surgery, and the minimally invasive surgery follows the concept of the traditional open surgery. Our team depends the UB technology. So as we know, the UB technology is becoming more and more popular. This is our team training. Our UB technical training course in China, and more than 300 doctors has participated in the training. And we have the UB Live Surgeon Shell and UB technical standardization training every month. It is the 34 sittings now. So our UB technology, the concept is following like this. Firstly, is minimally invasive in soft tissue. Secondly, is clear opening fields. And thirdly, flexible opening space. And fourthly, minimal invasive procedure, including controllable and safety of many populations. And finally, the minimal invasive and non-invasive spinal nursing in our hospital. So, what's the real minimal invasive spinal surgery? The core concept of the minimal invasive spine including will be the first difference between the minimally invasive surgery and open surgery is the minimally invasive soft tissue. For minimally invasive spinal surgery, the most important thing is the minimally invasive or non-invasive spinal cord and nerve steering the operation. In the ossification in the ligament periphery in the thoracic spine, we chose the UB technique for the toe leaf because the convention of thoracic laminectomy decompression is the standard surgery approach for ossification of ligaments fiber in the thoracic means the toe leaf, but it is high, traumatic, and risky. The UBE technique as a minimally invasive endoscopic surgery approach has the advantage of less trauma, clear vision, and safe operation. The ULBD by the UBE has been applied in the training toe leaf, such as this is a 69-year-old female patient. According to the MRI imagine, we can see the section of the T9 and T10 ligament periphery and the compression of the spinal cord. From the CT, we can see the ossification of the T9 and T10 ligament periphery and compression of the spinal cord. Examination of MR on the second day after the UB surgery show that the spinal cord stenosis was fully decompressed at the T9 and T10. From the CT, we can see that the ossification ligamentary fiber was completely removed. From the 3D CT, we can see the extent of the bone window and the faces joints are well protected. This is our surgical position of the patient. Place the positional vertical on the CM instead of the one patient. We use the following scopy, adjust the height of the head and tail of the operation bed, so we can confirm that the vertebral space is basically vertical to the ground. Second, the body's surface location based on the on standard anterior operation fluoroscopy, the location of the target point was marked on the bone surface with a line. The location of the target was determined according to the preoperative CT images. Then we will draw the work pool and the view pool in the patient's surface. This is the body surface location. We means the W and V location in their scene. And we then confirm the location. Three rings news were used to confirm the location during the operation. This is the position of the doctor during the operation. So there many doctors say that how to establish the W pool and the V pool. Firstly, we establish the W portal, and then we establish the V portal. The incision is made only from the skin to the deep fissure. Gradually expand the soft tissue to form the portal without the thinning of the to avoid the demanding too many muscles. The W portal is closer to the target and more perpendicular to the target, so that the operation to details less and the operation is more convenient, and is more similar to the operation method of traditional surgery. How to find the vein quickly? Our habit is the implantation of the endoscopic shear graded by the primary guide route. And locate the W portal gets under the endoscopy view, mainly establish and rapidly place the RF. The W portal is closer to the target and more perpendicular to the target, so that the operating tools are detailed less, and the operation is more convenient, and is more similar to the operation method of traditional surgery. After exploring the laminar, we use a grading drill to grade out a piece just enough to hold the grading bits at the junction of the spianosis process of the laminar and confirm the location. This is the location after exploring the laminar. This is the way can confirm the location in the C-arm. Based on the position of the endoscopy position and the pre-operative imaging, 4 millimeters grading drill can be used to measure the range of the initial bone, remove the window to the outside and to the end to the head. Gradually exploring the proximal to the ossificate ligamentary floor with the grading hill. The junction with the laminar is the boundary of the proximal decompression. And then we use the grading hill was use the expose the junction of the super edge of the inferior laminar and the ligamentary flamer. This is the boundary of the distal decompression. There should be enough space to avoid the compression of the spinal cord during the operation and ensure the safety of the operation. Then we gradually remove the outline of the contralateral ossificate ligament flamer. Grading in thin ossificate ligamentary flamer layer by layer. After confirming that there is no adhesion between the ossificate ligamentum flamer and the dural metal, the loose ossificate ligamental flamer is lifted away from the dural metal with a prying hole for removal, which is non-invasive and safety for the spinal cord. Then we lift and loosen the contralateral ossificate ligamentum flamer and breathe it as the contralateral marine. Lifted and loosen the constricted of the links flamer and break it out as the concentrate marine. This is the way we use the bone knife to the flamer. Okay. Then we remove the loose ossificate the yellow ligaments and complete the decompression. I will share one case in our ULBD for the TOLIF technique. This is a 71-year-old female patient with bilateral lower extremity weakness and unstable walking for 6 months, which gradually worsened and prevented her from walking for months. Based on the CT, we can see the olive caused several spinal stenosis with possible during ossification. This is the CT images. From the MRI images, we can see that the olive caused by several spinal stenosis. We first draw the work pole and view pole in the C-arm. This is the C-arm location of the W ports and the view ports. Then we reconfirm the location. Considering the possibility of the dual ossification, the ossifixed ligamentary flare was granted as thin as possible to allow it to float and achieve the purpose of the decompression. During the operation, we did find the area of the dual ossification was large and could not float. So we cut the off-linked yellow ligaments that have been grounded to the paper seam from the middle, so that they can float like the wing of the butterfly. The edge of the ossifixed yellow ligaments that need to flow should be completely loosened so that they can fall or floated. The ossification further is fully floating. The decompression is sufficient. Then we put the drainage tube in the wood. From this image, we can compare the pre-operation and the post-operation. For the thoracic spinal thoracic, we recommended adequate and even invasive detection because it's very difficult for us to reoperate on the thoracic of table. This is MR image compare the pre-operation and post-operation. We can see the nerve can flow out in the jaw. The patients after the operation, the patients was able to work on the floors for 4 days after operation, but she can't work before the operation. This is the 6 months of the operation. The patients can work return to the normal, and the MRI imagine shows that the dural matter space was recovered well. So we can see that the UV technology for the TOLIF is very well. So I can conclude that this speech is the ossification seed of the ligament the flavor was used as a target to establish the portal, and the technique of the safe to use the grading drill is very important. The concept of non and minimally invasive of the nurse should be carried out throughout the operation. If there is during ossification, we can use the method of make it flow, and we can also achieve the purpose of decompression. For the TOLIF, the UVE technique is subversive with clear, safe operations, sufficient decompression, less trauma, and good effects. So this is the why we chose the UV techniques for the patients. And the UV technique is a recommended method for the treatment of the TOLIF. Thank you. My speech is over. Thanks for your listening. If you have some questions, please tell us.
Thank you, Shin, for this nice presentation. Is there any question? Thank you.
Yeah, one quick question. Is that Juha's old hospital? Juha Hernes Nevi?
No,
No, it's
it's
not? Okay, okay.
it's another one, nearly the same name.
Okay.
Okay, next will be Dr. Song, Confing Song. Please start sharing your screen.
Everyone. Hello, dear Professor Simon and the host to join the good morning.
Morning.
And next I will show my screen. Wait a moment. Can you see my slide?
Yes.
Okay, wait a moment. I will.
Please make a presentation mode, please. At the very bottom, there should be an icon.
Yeah. Okay.
Perfect.
Yes.
Thank you so much. Good morning, everyone. I'm Dr. Song Wenfeng from Third People's Hospital of Hunan Province, Zhengzhou, China. I'm same to the Dr. Shen Mingkui and Dr. Yang Hejun. We are in the same department of minimal invasive spines World 1. And our department is National Clinical Special. That is my email and WhatsApp. Welcome everyone who can contact with me with email and any contact details. And today I will share my new topic. My name is the automated secret blood CUPE minimal invasive surgery. We know the UBE technique is popular in China and Korea. Yeah, so it's a good technique for the spine degeneration, especially for lumbar stenosis and fusion, right? First of all, I will introduce my hospital. The biggest minimal invasive center in China is about 700 miles away from Beijing, and yes, from 700 miles away from Shanghai, in the middle of China. Is our hospital's picture, and the right side is our hospital's picture. Then the first I will introduce my my department technique development from 1-point technique to 6-point technique. And from 2010, our hospital prefer PLD, PID for discectomy for the LDH, right? And after 4 years, we use the ring-saw to the UBE, to the ULBD for laminectomy, to the lumbar stenosis. We can do the cervical stenosis and the thoracic stenosis. 2018 years, we take the 4-point technology, 4-point level technology for endodontics, and yeah, and for the lumbar instability and spondylocities. And before the pandemic, we can do UBE for cervical, thoracic and lumbar stenosis. The importance of Dr. Yang of our two physicians in our department in innovation of new is MOECF and MOEACCF. And next, I will show some cases. In the last year, we create a new name, means Planis UBE. And in our department, everyone can do the PDB from and it will be more safe and more efficient. In the future, maybe AI assistance, not study technology will become right, and so we from input and topic. Until now, we do a lot of bipolar surgery, means OB. And next, I will introduce my today's slide for six. One is definition and definition of blindness UV. The second is pre-utilized for mastering blindness UV. Three is core elements of mastering blindness UV. The fourth is the steps to mastering blindness UV. The five is other factors of mastering UV, blindness UV. The six is topical cases, summary, and the first definition. This is my opinion. In my opinion, except for incision blade bleeding, more than 95% of the anesthetic operations have all clear field of view without red screen. The anatomical structure recognition is 100%, and the amount of anesthetic bleeding is negligible. Beneficiaries minimize the risk of surgical complications and improve surgical safety, minimize infective operations and improve cervical infection efficiency. It is just declarations speaking. I will have same opinion. Minimize cervical. The third is minimize cervical trauma and facilitate the rapid recovery of patients after surgery. The fourth is benefit for the training and the teaching of UV technology. The fifth is benefit the standardization, regularization, refinement, and intelligence of UV technology. The last is benefit for integration and innovation of UV technology and tools. Prerequisites about including six. One is equipment of tools to each team, including anesthesia, assistant, and nurse. The third is basic skills of a surgeon. Fourth is operation volume. Five is pre-operate planning and design, position, marking, incision. That is one is the surgeon's and then I will describe every details. First, the equipment and the tools we use. Install brand equipment like stores, steering light, visible cables, and the power drill system, and the handle maximum speed of about 50,000 multiplied greening set. That day speed change stop when board is released. Plasma, and then the plasma reduce frequencies to the system. We use the bonds brand and reduce frequency play when each of large and small bonds and season. Yeah. In the presence, the bond brand is very useful in our country, and another brand about another of green power drill system is three. The three brand is very good. Next is teamwork. I think it's important to the surgery. specialized anesthesia notices. Maintain deep muscle relaxation and lower and stable blood pressure throughout the operation according to the duration of the operation. Third is fixed force assistance of both an absent and of best partner. They can hold the mirror, tapping, holding the arm. It's two worse. Similar with the surgical procedures, instruments and surgeons operating habits. All of them can increase the surgery is not critical. So safe and efficient UV surgery cannot be separated from chemo. Third is basic skill of the practitioners. One is neurosurgeons splanectomy, endoscopic anatomy, and surgical ideas open or endoscopic surgery experience. Second is adapted to hand-eye separation operation, adapted to single-hand microscope, single-hand laminectomy, laminar and drip printing and drip printing is 3.22. Third is standardized surgical operation. Four, including all operations are away from the geometric nodes, part, plan, by, prone, result. Each step of the operation is performed under visualization, removing yellow ligaments near the nuclear purpose, parting and protruding in vertebral disc, claiming fat tissue, burning, bleeding, points near the dual matter. Typically, the dorsal bone of the nerve. So there is the surgery value in our department from 2018 to 2023. There are more than 2,000 cases of the spine disease. So in the 2022, we only do the 719 cases because of the pandemic. And most of them we do the UV or the endoscopic surgery. This cell I want to show my mean that is practice makes perfect. But is the pre-operative planning about including position, marking, fixation, and just depiction to the picture we are seeing. Every case is we need the right side position X-ray and the individual side X-ray, and mark every patient. Let's see the position. We use the 3 needle. The one, look at the first one is the middle, in the middle of the disc, and the right side is the portal, and the left side is the view portal. Is the procedure of the put the scanner, and last we use we can scan the X-ray to see the right and the lateral side to ensure the key level. Then take the proteins mentally and the personality. The end of the surgical practice is correct, except from the official account from another people. And reshapes the character and the character of practice surgery. When a person's basic skill, realize the knowledge and the specialized skill measure. A character will have a great effect on surgical quality. Therefore, the end of the surgical quality is practical. One, non-invasive, minimal invasive step to patient blood pressure, temper, and staging pressure, irrigation, water pressure, muscle relaxation, maintenance. It hemostasis throughout the process. For the both hand coordinated stable vision. It's for elementary is very important to ensure that the entire view is very clean. But it's done in invasive and minimally invasive concept, including 7 1 while the micro-invasive experiment of muscle and soft tissue, micro-invasive experiment of bone structure. 3 is operation to removing the ligaments for non-invasive micro-invasive experiment of nerve spinal cord. 5 is operation to handling development. 6 is operation to handling a development space and the terminal target. 7 is operation to inserting fielding devices. The third is the remote state of homeostasis in the whole process. 1 is micro arteries and macro visible in the microscope, and the second is cellular bone surface and nutrient prominent. There is a muscular network in the cranial caudal insertion area of the yellow ligament. Vascular network on the surface of neural matter. 5 is the vascular network on the vertical side of the neural matter that takes the vertical network in the intervertebral terminal. Because it's push and coordination, stable vision. Keep the lens 1 to 1.5 centimeter away from the target during the whole process. Keep the same angle and that each time the instrument enter the operation channel from muscle memory. Use the grading head as much as possible when proceeding bone tissue. The key steps about clothing 4 points. 1 is pay attention to the establishment of the initial interior technology, wash and remove the blood. Expand the scope of the image you can. The scope of the bone decompression. 3 is pay attention to homeostasis of every tiny bleeding point of or area. The 4 is pay attention to interface experience. Okay, after about including 5.1, but after that, I can make every operation studies. You can believe, I can believe, you can believe. The second is there is not enough patients to do every detail well in mental injuries and makes the waste. The 3 is carefully try to change the habitual dangerous operation and be good at improving before planning. This is before operation. The 4th is step by step from slow to fast. First, the impression L5S1 and L4 to 5, and then fusion from L45 to L5S1. The 5 is pay more attention to and watch the UV operation line protects the zone of the capital of quantum provision in online public academic service in and GUBE at and then upload every Tuesday, every evening. Last, I will show the lab link. Next is typical cases. I will show 5 cases, including minimally, including ammonia ECDF, ammonia ECCF, UB, ULBD, UB, UBD for statistical and span stenosis and span number billion. With 1 minimum physical. EDF and CF is innovation in 19. So we will have Professor Robert Robinson first and the anterior approach in 1953. And another professor, Ralph Cloud, used the store integration in expanded bone perfusion in 1958. Cervical secondly, the decompression diffusion is still the gold standard for the treatment of cervical spondylosis, especially for spinal cord type. We can see the first cases. The man, 38 years old, is the T level is cervical 6 and 7. Pre-operative and the post-operative, we can see the DLT case is very good. Then this the MRI, pre-operative and the post-operation, pre-operation and the post-operation is very severe pressed by the dystonia detonation and the spinal cord was pressed into the color to white. And after the post-operation, we can see the face is not good. And the CT scan after the operation is very good too. And the detonation is very enough. This is the procedure. We don't need 1.5 incision. But the pestis muscle and the finger and use the index finger to touch the front of the vertebra. So explore the prevertebral fascia and preventral fascia incision. Operation needle placed in vertebral body and the repacture hole to expose the surgical field. Applying the annular fibrous scraping of the internodular disc, and then scrape to the posterior edge of the vertebral body, and then scrape to the vertebral joint on both sides. So we can see the view is very clean. This is in area phase. And then we can enter the field of fusion and water medium. We use the power drill to remove the posterior edge of the vertebral body. The frequency anesthesis bone, and if there's some burning, we use bone wax. This is species. So we cut the posterior longitudinal ligaments compared to the compression on the right side view. So this view is different from original ACDF. Proceeding the upper and the page again and here on the page. So after decompression, we remove the water and the verification on the ear medium microscope and place the 12 more. placement of fueling cage and the screws, and the fueling cage is placement on the right fueling. And the second case is D304 MOU ECCF. This is a severe discoordination and place the core very objectification and preoperative CT scan. And right pre-operation, we can see the reform is very severe. And the spine corner is very severe. But in the same way, we use the drill to removing the posterior margin of the vertebral body. We use the propofol to peel off the authenticated posterior latitudinal ligament. Finally, we decompression completely. You can see the video is very good and we remove the oxidate posterior longitudinal ligament. After surgery, we scan the CT scan and the X-ray. We can see the picture is very good. The impression of the line is very good. You see the CT scan. There is stressful UV durability. This case is just shown by distribution Ming Hui. We start fast. Both cases is to be ready for lumbar stenosis. It's 2 level position. We receive and post-operative CT scan and MRI scan. There are 4 level. Operation and the post-operation in the CT scan. You see the video. All video is very clean, and there's no blood, no red screen. After surgery, we scan the CT. We have to scan the CT scan. We can see the hole, the double hole. And our center is the entire stuff. Next case is L45 for UV leaf. It's very in 3-degree stenosis. It's most part. Pre-operative imaging, including CT scan and MR scan. And we use the bipod, the BLPD. The surgeons stand the right side. This is the position. 10 mark. This is the mark. And we first put is this into operation. Because of the time, I will very fast. We can do the offset after we can do the same side. Okay. Take-home message: minimally invasive spine surgery has become one of the most important minimally invasive surgical method in spinal surgery because it is born for stenosis and is a gentle learning curve. More and more spinal minimally invasive instances are flocking to it. Although UB technology is simple and easy to learn compared to other minimally invasive surgeries, resting dural routine postoperative infection, aggravation of postoperative symptoms, or poor postoperative result often occur. But UB minimally invasive surgery has taken this minimally invasive technology to a new level. The above mentioned related applications will hardly occur thanks to the clear field of vision, high resolution, anatomical structure, and standardized operation procedures provided by UB technology. In the future, planning to be minimally invasive spine surgery may become the gold standard or surgical guide for the treatment of degenerative spine stenosis and local space occupying lesions of the spine channel. The tips, the practice before surgery, skill during surgery, and diligence after surgery. Strictness before surgery refers to strictly grasping the indications for surgery, ensuring the necessity and the feasibility of surgery. Skilled during surgery refers to mastering surgical technologies with great skill to ensure the success of the operation. Diligence of the surgery refers to pay close attention to the patient's recovery situation and ensuring that they receive timely and effectively rehabilitation care. These three links are closely connected. Motivate influential and indispensable. Last, thank you for your attention. These two links in our hospital's live surgery, live link, the full surgery, and you'll be spine surgery free life thing. So I suggest everyone to save these patients, to save this page, and to follow our WeChat, WhatsApp, and the Facebook. Thank you so much. So,
Thank you, Dr. Sung, for this nice presentation. Is there any question? Thank you.
much. Thank you.
Thank you.
Thank you, Professor Simon and host.
Thank you.
Thank you, everyone.
Okay, next speaker, Professor Francisco Zinga, and Dr. Yagi will deliver his own lecture. Please, Dr. Yagi, start sharing your screen. Dr. Yagi. Hello?
Is he there?
Yes. Okechi Yagi. Hello? Dr. Francesco.
Oh, see, hi, my name is Yagi. I'm presentation. I will presentation about presentate about the transfrontal sinus approach for anterior cranial fossa regions. Okay.
Okay, please start showing your screen.
Okay, just a moment. Just a moment.
Perfect.
Can you show the picture?
Okay, go
Okay.
ahead.
Yeah. Thank you. My name is Ryokichi Yagi from University of Turin, Italy. Today, I'm talking about the transfrontal sinus approach for anterior cranial fossa regions. There have been many papers on the approach to the anterior cranial fossa regions in the past. The approaches can be broadly divided into three. There are mainly the frontal approach and frontal lateral approach and terminal approach. In particular, the frontal approach included the frontal interhemispherical approach, frontal basal approach, extended frontal approach, transfrontal sinus approach, and endoscopic transnasal approach. The transfrontal approach, a transfrontal sinus approach has been reported since 1990, and the actual technique has also been reported. Francesco Jenga reported on the surgical outcomes of olfactory groove meningioma in 2020 and stated the importance of these 6 points. First, early access to interrupt vascular supply during an early phase of surgery. Second, early identification of the neurovascular structure in order to preserve them. Third, minimal retraction of the brain. Fourth, complete removal of the dural insertion of the meningioma achieve the symptom grade 1. And fifth, good aesthetic result. The sixth, low complication related with closure. For example, the CSF leak. About the frontolateral approach are weak for early identification of normal structure and for the cosmetic after surgery. The supraorbital approach is good for the aesthetic result. About the terminal approach and front zygomatic approach, there are no major advantages, but they are popular approaches and have a low complication rate of CSF leak. For the frontal approaches, there are many advantages on extended frontal approach, endoscopic approach, and transfrontal sinus approach. With these approaches, it is possible to reach the origin of the tumor directly, which improves the reduction rate. Furthermore, the endoscopic and transfrontal sinus approach are cosmetically preferable because they don't cause skin depression due to bone defects. The transfrontal sinus approach accomplishes all 6 points. This is a case, the olfactory groove meningioma case. This shows the MRI enhanced and T2 images. The symptoms are headache and anosmia. The T2 MRI shows a huge edema bilateral frontal lobe. This is the positioning about the surgery. The midline, supine, and the head position is slightly elevated to level the anterior wall of the frontal sinus. The head beam is considered with a skin incision. About the procedure of craniotomy, we make the bicorneal skin incision, and the important thing is carefully correct the pericranial flap. To open the frontal sinus to its base, the front nasal suture must be exposed. Also, the supraorbital notch is landmark of the lateral side of the craniotomy, so it must be confirmed. For cosmetic reasons, screws are placed in the advance with titanium plates. This is a movie of the craniotomy. The pericranium flap have to correct gently. It's important for the closure of the dura. So and have to confirm the orbital limb and also the front nasal suture. And the symbol is used to reduce bone defect, and only the anterior wall of the sinus is corrected. And use a chisel to fracture the septum. And enter the frontal sinus. So next, the base side of the dura is important to exposure by resecting the crista galli and opening the ethmoidal sinus. It is possible to focus on tumor without exposing the normal brain parenchyma. And the tumor is devascularized and detached and is removed. This is a movie. The bone, the posterior wall of the frontal sinus is thinned with a drill to expose the dura. In order to reach the tumor origin from the extradural space, the frontal sinus and ethmoidal sinus are opened, and the mucosa is removed to prevent the mucocele. The crista galli is removed. The anterior and posterior ethmoidal artery, which are the feeding artery, are coagulated from the extradural space. And the tumor is decompressed using the ultrasound scalpels, like this. And tumor remove can begin before the opening the dura. And also coagulate the feeding artery. The dura mater is incised, and the tumor is separated from the normal brain parenchyma. At this time, care is taken to preserve the arachnoid matter to prevent the damage to the normal brain. So this layer is important to eject from the normal parenchyma. The tumor is reduced in volume, and total removal is achieved. This is normal structure, posterior side of the tumor, and it's easy to see the normal structure after debarking the tumor. Have to continue the detach from the normal parenchyma, and finally we can remove the tumor. And finally, the attachment is coagulated again. And for the closure, to prevent the CSF leak, the frontal sinus is cranialized using an artificial dura and the pericranial flap. This is a postoperative CT scan. There is no cerebral contusion, especially on T2, and cerebral edema has improved significantly. These are pre and post-operative MRI, which confirmed the total removal. The transfrontal sinus approach has also been reported to be useful for osteoma in the frontal sinus. So we have also have this case in a 68 years old man and with infiltration from the frontal sinus into the orbit. And symptoms, the proptosis and visual field defect. The positioning is the same as the previous case. And this is the after opening the anterior wall of frontal sinus. The tumorous bone is removed with the drill. And the tumor is removed piece by piece. The surgeon can feel the difference between the normal bone and tumorous bone. But it's difficult to confirm where I am. So we usually use the navigation system in this operation. It is possible to remove the tumor without compressing the brain parenchyma, or of course, dura and brain parenchyma. So this is the wall of the periorbiter. So if removed, you can see the periorbiter. So this is the most lateral part of the tumor, and have to protect the orbital periorbiter. This is the last part. Okay. And this is the postoperative CT scan, which shows the total removal. Yes. The conclusion. Is there any reports about the approaches to the anterior cranial fossa and frontal sinus? The approach should be determined based on the tumor size, histological diagnosis, patient's age, medical history, skull shape, and the relationship to the vascular nerves. Transfrontal sinus approach has many advantages for the surgeons and the patients. Thank you very much.
Thank you, Dr. Yagi, for this nice presentation. Is there any question? Thank you.
Thank you very much.
We will wait just for 2 minutes to Misra to join us and present his own presentation.
Okay.
What's going on, Sam?
We are waiting for Basant Misra. He is just trying to get online. Just 1 minute. We can change the tape, John.
I'm sorry?
Change the tape of YouTube.
You're going to mute?
Yeah, yeah.
Oh, so we have a break now?
No, please change the YouTube tape.
Change the what? Can you write that, Sam? I can't understand you. Write it right in the chat. Oh, change the YouTube record. Okay, we'll do that. Okay. Oh, I can't do it, Sam. You gotta make me the host.
Okay.
Okay,
Done.
okay.